Good morning.
Very good morning, sir.
Anand, how are you?
I'm fine, sir.
Okay, great. Apurva?
Good morning, sir.
Good morning. Others have not joined yet, I think.
Just a moment, sir.
Good morning, Rupesh.
Good morning, sir. How are you?
Can you see me? Good morning. Very good.
Hmm.
Can you see me?
I can see your name, but not video.
Oh, okay. Let me see how to do it. Video.
વિડીયો ઓન કર એના પર ક્રોસ મારેલું છે ને ચાલુ કર અને હવે અહીંયા વાતો નહીં કર નહીં તો બધું સંભળાશે.
Okay. Now can you see me?
No, sir, not yet. Yes, now we can see you, sir. Good
Okay.
morning.
Okay. Yeah. Good morning. Bolo.
Looking
How are
as fresh as ever.
you? Well, thank you. Thank you very much. I'll be touching 80 complete.
I know, sir. I know.
So, but fortunately, I'm still not overactive, but active enough to keep reasonably busy.
Right, that's good, sir. It must be like that.
Good morning, sir.
Good morning. Good morning. How are you?
Thank you, sir. Thank you for joining. સાહેબ અચલ ગુપ્તા તો કંઈક મીટિંગમાં જતા રહ્યા છે. મને સોરીનો મેસેજ બી આવ્યો. મને કે હું નહીં જોઈન
Okay,
કરી શકું.
no issue.
No, we'll
પણ
take care.
જેઠાલાલ is also અને હર્ષલભાઈ જોડે બી વાત થઈ જાય. He is also joining.
I think Jitendra I can see. Good morning,
Jitendra, good morning.
Jitendra.
Good morning, sir.
Good morning. Very good morning.
તો shall we start, sir?
Oh, yes.
Thakkar is joining.
હા સર,
Who?
સોરી સર.
Anand Thakkar.
હા, he is joining. એણે મને 15 મિનિટ કીધું સાહેબ.
Okay, no issue. That's all right. We should start. It is
Yes.
Yes,
it is-
yes.
2 minutes. It is not yet 9.
Okay, we'll
Okay.
wait for 2 minutes.
Meanwhile, I introduce everybody and rules. My one request is that let us give more concentration on clinical, sir.
Yeah,
Because
100%.
other things the students will read, but the clinical they are lacking. Lot of problems we have faced. So
Yes. I agree.
So basically, sir, as Dr. Pankaj Modi sir said, we take this as a PG exam, like PG the case presentation in the long case of exam. The only thing is it's on the virtual platform. We have the patient is there in the ward. We have photographs of the patient and all the investigations with the candidate. We allow him to complete. The only thing is we allow him to complete the history part first, then we ask the questions, and then the investigation and the treatment part. In between also, you can stop him at any given time. We have experts with us so that we can cover the topic in toto, but basically more concentration is to be given on the clinical examination, because that is what, as sir said, is right, sir. They lack a lot of practical tips when it comes to case presentation.
I agree.
In the morning, we have stalwarts, and I'm really thankful to them. Dr. Rupesh Mehta, almost everybody knows, sir was HOD at VS Hospital and probably one of the earliest to start endoscopy in Ahmedabad. Right, sir?
First one, not earliest.
Oh,
First and in Gujarat. And nobody has given me correct answer that I started gastroscopy in 47 years before.
Oh.
Okay, sir.
So,
thank you, sir.
People say 10 years, 20 years, 30 years, but not 47 years.
uh,
morning,
we
sir.
have Dr. Jitendra Darshan, who is the HOD and Superintendent, Smimer Medical College, Surat.
Hello, sir.
We have
Hello.
Dr. Anand Patel. He is a MCH gastro surgeon, practicing at Noble Hospital, Ahmedabad. And
morning,
Dr.
Rajesh.
Harshal Patel, who is a DM gastroenterologist. So, because it's a case of portal hypertension, we would like to cover it up completely. We'll be joined by Dr. Anand Khakkar, who practices as a liver transplant surgeon. He is going to give us an overview on liver transplant to all the PGs. Sir, you are muted.
At the end of the lecture.
Yes, at the end of the session. Yes, at the end of the
So
session.
the PG should continue.
Yes.
Right.
So the PG should continue even after the case presentation is over.
And that we will allow him to speak about the history completely. Then we stop him and ask the question slide by slide. After that, completion of examination and clinical diagnosis, followed by later on investigation and management. That is usually the way we do that. So let him complete the history first. Then you can ask the question for the persons who have joined for first time. Okay.
I would like
Welcome,
to
Harshal.
congratulate. I would like to congratulate Pankaj and Apurva for doing excellent work. I'm sure in our days we had no such facility. So again, repeat congratulations, and you are doing excellent work for junior doctors.
Thank you, sir.
Thank you, sir. And I thank Dr. Pankaj Modi, sir, to keep me inspiring.
Even though I have retired, at least from civil hospital.
Yes, sir.
Okay, Satyam.
Yes, sir.
Yeah, please share the slide.
Share your slides.
Sir, I am unable to share it.
Oh, great.
Okay.
What is the problem?
Karan, who is there? Tari paase 6 slides.
These are the technical problems arises every year because as the old residents pass out and the new will come, they will again have to relearn everything like that.
Satyam, you send the request. I think the host would have that request.
Where is host? PG Masterclass. Who is running the host just now?
It's I will move to Karan Kunj.
Yes, sir, we are working on the
Yeah.
issue.
Okay,
Yes,
fine.
great. Meanwhile, Anand, I saw you on that day.
Oh,
I
yes,
came for
sir.
half an hour for that
Yeah, sir.
unrelated lecture.
No, sir, your lecture was fantastic. I just can mesmerize my own PG days.
Because so they had given a lecture in Ossicon to me on the clinical scenario. Means what is happening in today. I said that MCQ should be banned. I am really very pissed off because I have not seen any undergraduate student attending the clinic in last 10-15 years. As
Yes,
soon
sir.
as the second MBBS stage, they start attending some classes, this, that, and read the MCQ books, 5,000 MCQ. So it is just rotting up, nothing. They don't see the patient, they don't put their hand on that. And now it is becoming same in PGs also.
Yes, sir. Yes, sir.
They want to complete work and start reading for MCH. And that is MCQ again.
Rupesh bhai, you are muted, sir. Rupesh bhai.
Sir, you are muted.
अरे Kunj, unmute Rupesh bhai. Sahib, if you can unmute yourself.
Okay,
Yes,
now,
sir. Yes, yes, sir.
I have one more comment.
Yes,
that
sir.
don't blame PG students.
Ah.
But even consultant also, moment you go in, with due respect, they don't put hand on the abdomen. Straight well, they will say CT scan, MRI, this, that, and blood test.
Sir, this was the part of my lecture. I said the same thing. Nowadays, round starts with sonography finding with this.
Exactly. So,
Yes, sir.
So that is, don't blame PG. That's what I said.
System, I would blame system.
System.
Yeah.
May I
In
take it full screen?
consultants are there in, I'm talking of medical college, not of a private. They are just there. I don't know why, but nobody is interested in taking a proper round, taking a lectures, teaching the students before surgery, during surgery. Very limited. I don't know. Apurva can tell me more.
You are right, sir. Everybody is interested in surgery only and only in surgery, not
That's
even
all.
pre-operative, post-operative, nothing.
Okay, let us. There's a very
Yes, sir. We'll
long
start.
topic. Yes, start. Let us start. Satyam, start it.
So, good morning, everyone. Good morning, sir. Sir, I am a third year resident presenting case of portal hypertension. Next slide. Next slide. 30-year-old chronic alcoholic male, resident of Raipur, Ahmedabad, laborer from a low socio-economic class, presented with chief complaint of abdominal distension since 1 year, blood in vomitus since 1 day. History of presenting illness. Patient was relatively asymptomatic before 1 year. Then he developed abdominal distension, which was insidious in onset, slowly progressive till day, and without associated with abdominal pain. Developed sudden onset of blood in vomitus 2 episode, bright red in color, non-projectile, 6 hours apart, without food particle and blood clots, not associated with nausea and retching or meal. No history of melena, bleeding per rectum, no history of sleep disturbance and tremors, no history of jaundice or similar complaint in past, no history of bleeding diathesis, blood transfusion remote or recent, no history of weight loss, anorexia, no history of cup breathing difficulties or fever, no history of umbilical infection in past. Next. Past history, not a known case of tuberculosis. Past history, not a known case of tuberculosis, diabetes mellitus, or hypertension. No past history of any intervention or hospitalization. Personal history, consumes mixed diet. Patient is chronic alcoholic for 15 years, takes 1 liter per day, and last consumes 1 day back. Normal sleep with reduced appetite and unaltered bowel and bladder habits. Sir. Family history, not significant family history, sir. Summary, 30-year-old male patient, chronic alcoholic patient, presented with abdominal distension since 1 year, with acute episode of hematemesis since 1 day, without jaundice melena, similar history in past, or any intervention.
Okay, sir. Go back to first slide. Sir, would you like to ask? Unmute and Rupesh, sir, Anand.
Satyam, go back to the first slide.
Sir, Yash is a control of this.
Oh, Yash, go back to the first slide. History.
Yes.
Yes, sir.
Rupesh bhai,
Yes.
please,
No,
sir.
no, I'm there. I'm there.
Yeah. Would you like to ask anything about the history part, sir?
Nothing special because alcohol,
Anand?
and he said the large quantity every day.
Mhm.
I'm still wondering he's only 30 and drinking for last 15 years. So,
Okay.
Satyam,
Next.
can you
Next.
tell me what type of alcohol he is consuming?
Sir, countryside.
Why is it important?
So because countryside alcohol containing methanol, which is more harmful than branded alcohol, sir.
my dear friend, all alcohol are bad, whether it is countryside or the regular one.
Yes.
Anything outside the limit is bad.
Yes, sir.
Next slide. Yash. Okay.
He had abdominal distension for 1 year. He never visited any consultant. Anybody? Meantime,
No, sir. No, sir. Slowly progressing, so patient not give a thought of it.
Okay. So what was the color? What does it suggest when you say it is a bright red in color?
So bright red in color means it's a fresh bleed, not congested one, which is
So
collected in
what does
stomach,
it,
sir.
I am asking you, what does it suggest? Obviously, description is not what I am asking you. When you say it is a bright red in color, what does it suggest? What gives the idea that what can be the cause, in other words?
Varicose bleeds, sir.
Huh?
it like
Varicose bleed.
how can you say simply directly varicose bleed? સાહેબ શું પૂછે છે bright red color હોય, what does it suggest? From see, you cannot say for sure it is hematemesis or varices. But what sir is asking is from what could be the source? Upper GI, lower GI, mid
Yes, sir.
GI.
Yes, sir. Sir, upper GI source.
Acha, from stomach, you want to say? So let me ask different way. What are the different kind of blood in vomitis? One is you say bright red. What else it can be?
Sir, it can be coffee ground appearance.
So what is different?
Sir, coffee ground means which blood collected in stomach, which is digested and converted to acid hematine, which is vomited out.
Dr. Hemant Prajapati, please mute yourself. Please. Yes, thank you. Yes, Satyam, you were saying something.
Sir, coffee ground means blood is congested and digested by the acid and converted into acid hematine, which gives a coffee ground.
Agreed.
Okay.
Agreed. When then white bright red, what does it suggest? It's a very simple question. You understand it, it's fine.
Active bleed, sir.
I have not asked me question.
It suggests active bleed, sir.
Active bleed means what? Does that something to do with the amount? Do you understand?
Yes, sir.
Along
Profuse
with
bleed.
active bleed, it is amount and continuous bleed. Coffee ground suggests that the slow bleed collected in stomach, digested and altered by the gastric juice. When it does not happen because of two reasons, where the persistent bleeding prevents that alteration because of the severe amount. Usually it suggests it is a fresh active bleed
Yes.
and amount is much, much more.
Yes, sir.
So in which condition you will find the bright red?
Sir, condition like varicose bleed.
One is varices, agreed.
Another one is sir, malarious tear, sir.
Malarious tear, though it will not be non-projectile, fine. What else? So, Satyam,
Peptic
I say
perforation.
you, because of the, let me ask, with all PGs, you are always you are always biased. Oh, this is a case of portal hypertension. So always think of only one thing, and that is varices. But remember, till you read the diagnosis, you cannot say there is only one reason varices. Even bleeding, gastric or duodenal ulcer, particularly posterior seating of the gastroduodenal artery, can give rise to severe bleeding. Right?
Yes.
Even in severe gastric erosion, there can be a tip. So what does it suggest is the amount. There is a copious amount that. So why there is no melena according to you?
Sir, episode is just 1 day ago. So duration is 1 day.
One day.
So
So what is difference? What is
chronicity.
melena?
Melena, digested blood coming out as a feces.
What does the melena suggest?
Blood is chronicity, sir.
No. Suppose after 2 days this patient has a melena, it is chronicity.
Melena suggests upper GI bleed, sir.
Yes. So answer exactly what is needed.
Yes.
It does not suggest chronicity. It suggests the bleed is probably upper GI. By the time it reaches rectum, it will be a intermingling with the stool and gives the typical black color of the stool.
Yes,
right?
sir.
So
Yes.
still blood has not reached there. So there may not be a melena. You also wrote the bleeding per rectum. Why did you ask that?
Sir, in cases like uh, portal hypertension, uh, there is a rectal varices which can have developed, sir, which can be bleed. So
Sorry, what is rectal varices?
sir, in case of portal hypertension, sir, there is a rectal varices which had been developed.
What is rectal? I have not routinely used word rectal varices. Sir, what do you say, sir? Anybody else? Anand?
These are all classical trap questions.
That's what, because they are always, that's why I say clinically, they are always thinking of treatment. That is the problem. If you ask him liver transplant, he will give you total. What is live liver type, what is cadaveric liver transplant, he will answer it properly. But what was my question? So did you understand the question or was there some problem with question? We don't call it rectal varices. What do we call piles? Do you understand?
Rectal.
Do
Yes.
they normally bleed in a case of portal hypertension?
Not, sir. Maybe in case of
Yes. Anand, you were saying something?
No, sir. I would always say that while he elaborate the taking a history of melena, he should ask whether he is passing fresh blood while defecations, exclude the hemorrhoids part.
Hemorrhoid.
And
Don't
yeah,
call it rectal
yes,
varices. You
rectal
may be
varices.
technically right, but it should be called hemorrhoid. Right?
Yes.
And it is not always necessary that the patient of portal hypertension will have a bleeding hemorrhoids. Why? Why usually in portal hypertension, rectal hemorrhoid or hemorrhoid do not bleed?
uh, sir, they are just dilated vein, not so,
Varices are also dilated veins.
uh,
Okay, let me ask you another way. Why the esophageal varices bleed? Single reason for bleeding of esophageal varices.
increase in pressure,
Yes, excellent. Which pressure?
venous pressure, sir. Portal venous pressure, which
Portal venous pressure, right. So my teacher used to tell me that it's a vent and most of the time bleeding will stop on its own also. Once the portal pressure goes down beyond that. But you have to sustain pressure patient during that time. That was the old adage, but the principle is that it is a venting of excessive portal pressure. So usually it happens at the varices site and not because the rectal hemorrhoid is far away and too small for that. So usually they do not bleed. But you should always ask history of that. I agree with you that. But you should know the mechanism behind it.
yes,
So which vessels are causing the what you were calling rectal varices?
uh, superior rectal, middle rectal, superior rectal connected with portal venous system part of a superior rectal vein and systemic vein, middle and lower rectal vein.
There is nothing like which lower rectal. Okay, I will let it pass. So you should understand. So it's a communication portosystemic between
Yes,
superior rectal, middle, and inferior rectal.
inferior.
Right?
Yes.
So you should understand the mechanism and which vein are causing the esophageal varices.
Left gastric, left gastric,
That's one.
and hemiazygous vein,
Which one?
hemiazygous vein.
Hemiazygous vein. So, which veins are in esophagus which communicate with the branches of left gastric? Esophageal veins draining the azygos system.
Yes,
That is a systemic part. So, you should know this part. So, okay, agreed. And why you have taken sleep disturbance and tremor before anything else?
to rule out hepatic sir.
So, when you are presenting a case, always divide it according to the symptom. Which is the patient's main symptoms?
Hematemesis, sir.
No distension.
Yes,
It is since 1 year. Though patient's emergency is hematemesis, but the symptoms is since 1 year. So what do you think the cause of distension?
Uh, so any liver pathology, so pancreatic pathology?
Cause of distension.
What do you think is the cause for that 1 year? Since 1 year he is having distension.
Ascites, sir.
Ascites, yes.
Yes.
So that might go. So what have you said about ascites? Cause of ascites, which you should have asked. Remember, a rarely ever patient of developing hepatic encephalopathy will come in your exam. So it is bound to be always no. But that should be, yes, included, but last. It should
Yes.
be your negative history issue in a preference, which is common. You have taken jaundice later on. Jaundice is a very important point, right? Similarly, blood transfusion is another important, and you have written very correctly recent and past. Both are important. We'll come to that, right? So sleep disturbance and tremor, I think for hepatic encephalopathy, that is a rare. It should not be included. It should be a last one,
Yes.
right? So why did you ask history of jaundice? Sir, are Anand there? I am taking, I am.
No, no, sir. I would
Harshal, you can
also
also
like to.
ask. Huh?
Yeah.
Yes, sir. One more thing you should have included in this negative history of abdominal distension,
Yes.
something related to urine.
Urine output, sir. And
Yes, yes, yes. Decrease in urine output.
yes, sir.
One more point for distension could be gaseous, could be uniform, or could be ununiform. That is abdominal lump. Probably you should have asked that question also.
Yes, sir.
So what did is distension decrease anytime?
No, sir.
Have you written that?
Slowly progressive till day, sir.
But where is that? Remember, ascites increases and decreases. Was any procedure done in between? If it is
No,
done, all students, you should write down that and tell about it. Right? Do you
yes.
understand? Did patient consult any doctor for distension?
No, sir.
Did not consult.
Did not consult it, sir.
Surprising. Okay. So you were talking about jaundice. Why did you ask history of jaundice?
Sir, to rule out hemolysis, or sir, rule out case of
What is
liver
the
pathology
relation
like
of hemolysis with this case? Remember, we are not talking of obstructive jaundice. We are
yes.
talking of portal hypertension.
Yes, sir. To rule out hepatic causes of portal hypertension, sir.
Which
Cirrhosis, sir.
which hepatic causes?
Cirrhosis, sir. Cirrhosis.
Hey, jaundice because of what can lead to cirrhosis? Chronic hepatitis. Which are the cause of chronic hepatitis?
Sir, alcohol hepatitis, sir. Or sir,
We are talking of jaundice. Where does the alcohol come in? We know it is because of alcohol, but you have asked history of jaundice. So, for some other case, why will you ask history of jaundice? Your thinking should be very clear. Just because of that, no history of jaundice doesn't save you.
so portal hypertension will lead to portal biliopathy, which
What is hepatitis B? CABC. Though Herschel can tell you more, but is there any bearing of that kind of jaundice with portal hypertension today? So when you ask history of jaundice, it is for two reasons. One as a cause of portal hypertension or cause of cirrhosis, and second is after effect of liver disease. In both such cases, there can be a jaundice. So let us talk about first. So you have asked history of jaundice when? Before 6 months, before 1 year, before 2 years. So what is your opinion?
Sir, recent jaundice will be decompensed. Nice. मतलब
Is it the time when jaundice occurred, or it is the duration for which the jaundice was there?
Harshal, can you elaborate on
Yes,
that? Because he is clueless as far as I am
yes,
concerned. Sir.
yes, yes.
Hmm.
First thing, Satyam, one
yes,
thing
sir.
is that sometimes most of the cases, even in the cirrhosis, we don't see jaundice. Those patients would be having bilirubin of 1.5 to at max 2.53 if they are compensated. So, if you find jaundice in a patient of cirrhosis,
Yes, sir.
what will you like to rule out? Suppose if you know that this patient is alcoholic and has cirrhosis, and he has recently developed jaundice, what would you suspect and what would you like to rule out?
To suspect cirrhosis, sir, and to rule out.
Cirrhosis he has.
Sorry, sir.
So, recent onset of jaundice in a cirrhosis indicates something sinister, like HCC or something. Another thing, you know the history that patient is alcoholic and he is developing jaundice in the background of ascites. Okay, so he
Yes,
may be having acute and chronic liver failure. Chronic failure due to alcohol-related cirrhosis. He still might be having some hepatocytes left, which hepatitis occurred because of acute binge alcohol or continued long-term alcohol. He might not have stopped it.
yes,
जब बिल्कुल ही सिरोसिस हो जाएगा, हिपेटोसाइट नहीं बचेंगे, तब जॉन्डिस नहीं होगा. और जो पोर्टल बिलोपैथी तुमने बताया वो अभी बहुत दूर की बात है, क्योंकि उसके लिए फिर मतलब बिलियरी ट्रैक्ट का ऑब्स्ट्रक्शन वगैरह चाहिए होगा, वो बात की बात. पोर्टल बिलोपैथी वो टोटली एक अलग ही चीज है. तो कॉमन चीज ये है कि एक्यूट और क्रॉनिक लिवर फेलियर मतलब ACLF, अगर सिरोसिस डेवलप नहीं हुआ तो एक्यूट अल्कोहलिक हेपेटाइटिस या तो फिर समथिंग नियोप्लास्टिक, ये
yes,
कॉमन चीज.
And suppose patient gives history of jaundice before 15 years.
Yes.
Though this patient is very young, but still, what else you would consider? Okay, let me ask you point blank. Can hepatitis B cause cirrhosis?
yes, sir. In chronic hepatitis, chronic viral hepatitis, sir.
Right? It can
Yes,
cause
sir.
both cirrhosis or even after cirrhosis, hepatocellular CA. Both are
Yes,
possible. Right? But we'll not go in detail of that hepatocellular. But remember, that's why you ask it. So just writing down history of jaundice doesn't save you. That's what I want to tell to all the students. Whatever you say, you should be able to explain it. Right?
yes,
You
sir.
have written bleeding diathesis. What do you mean by that? No history of bleeding diathesis.
So presentation of hematemesis.
There is a hematemesis.
History of bleeding diathesis in past can be
What? Which? What did you ask for that? You blind blank patient. Have you got a blood diathesis?
no, sir. I
So
will
what
ask
did you
for
ask?
bleeding gum or
Okay.
nasal bleed was or
Very good. What else?
any petechia or bruises development.
Okay.
Yes.
Why did you ask history of bleeding diathesis? I'm just talking the things which you will not thought of. You will have read everything about portal hypertension, how to do scoping, what is bending, what is gluing. You know that all. We'll come to that later.
To rule
But
out coagulopathy, sir.
that is right, blood. But why in this patient?
Liver failure will lead to decrease in production of clotting factor, which
So only in a case of liver failure it will lead to this. So what is function of liver?
uh, so metabolic function to neutralize toxins. One is a synthetic function, protein synthesis. Uh,
Anything related to blood diathesis.
Clotting factor production, sir.
Production of clotting factors, which is very important for that. Do you
Yes.
understand? So
Yes, sir.
remember, in a case of portal hypertension, there can be a bleeding diathesis because of two reasons. One is a decreased function of the liver or the liver pathology. What other function can be there which can lead to bleeding diathesis? Does anything to related to spleen you would like to discuss?
Uh, uh, reduction in platelet count, sir.
Why?
Sir, in case of portal hypertension or liver failure, sir, back pressure will lead to hypersplenism, sir.
You should have simply said a possibility of hypersplenism is always there.
Yes.
Right?
Yes.
In this case, in history, there is no patient has not complained of lump, so we'll discuss in palpation. Sir, anybody would like to ask anything?
Uh,
No, sir.
I think it covers almost everything. Jitendra Darshan?
Yes. No, continue, sir. Thank
Okay.
you.
So you have said go back. There is one more point I realize. No history of umbilical infection in past. What do you mean by that? Let me clarify this point.
Sir, umbilical infection will lead to left side portal.
I am interested. How did you ask that history?
जन्मता मतलब I have asked any there is any infection or any
Did you ask the patient had a home delivery or hospital?
हाँ.
No, sir, but I should, sir.
No, it is. That's the only way. Otherwise, it is very difficult. Why it is more common in home delivery?
Because clamping of umbilical cord at home delivery, which is a non-sterile technique, which lead to umbilical
No,
infection.
not because of that. You know that they apply cow dung on the
Yes.
cut umbilicus in home
Yes.
delivery. Nowadays, it's becoming less and less common. That's why I said you may avoid it, particularly unless it's patient. Did you ask patient? Patient's father, mother were there?
No, sir.
So how did you ask patient before 5? When he was 5, he might be. So these are the technical issue. It doesn't take away anything from you. But remember, it's a very difficult to elicit umbilical infection. Only thing you should know whether it was a home delivery or a hospital delivery. If it is a home delivery, possibility of umbilical infection is more likely. How does it causes the portal hypertension? History of umbilical sepsis.
Pathophysiology.
Yes, sir. Sir, umbilical vein, which is directly connected with the left side of portal vein, which lead to thrombosis of the portal vein, which lead to portal hypertension.
Which
And,
type of portal hepatitis cause?
Sorry, sir.
Which type it is? You know that there are 3 types. Anyway, we'll come to that in examination. But remember this point, when you say umbilical, you should be aware. Why do you
Yes.
have history cough, breathing difficulty and fever?
Sir, to rule out the hemoptysis, the
Pardon?
patient may confuse hemoptysis with hematemesis. So rule out.
So theoretically, it never happens. Huh, beta?
Okay. Any
Mathematics.
other cause for fever in a patient, alcoholic patient with ascites?
Acute hepatitis.
I am talking about ascites.
Pancreatitis, sir.
Oh,
Kirit, thanks for joining. You can chip in. What is the terminology SBP means?
Subacute bacterial peritonitis.
Always
Subacute
keep
bacterial
that in
peritonitis.
mind,
Yes.
especially in decompensated patients or something.
Subacute bacterial peritonitis. Yes, sir.
Next
Same
slide.
thing happens in exam also. Apurva sir had to say directly. Otherwise, you have to be on toes.
Anything in the past history, personal side?
No, no, I don't have to ask anything. Listen.
Next
Anybody?
slide. Next.
No. Just a minute. Just a minute. Just a minute.
Sorry, sir.
Go back.
Go back.
So, what significant family history you have asked?
Sir, family history of any death or any patient suffering from any liver disease, which
Which
may affect.
liver disease run in family?
Sir, Wilson disease or
Wilson
hemochromatosis.
disease. Agreed? Yes.
Hemochromatosis, sir.
Does portal hypertension run in family?
No, sir.
It can. Which condition? Though it is rare nowadays. What is Budd-Chiari syndrome?
Yes, sir. Congenital wave formation in the IVC, sir.
Okay.
Yes.
So, any other family history? Suppose the same patient is a female. Would you like to ask any particular family history? You know what is NCPPF?
Non-cirrhotic portal fibrosis, sir.
So, what is the usual presentation?
In mid-age with mid-age female with a lump, sir.
Lump? What lump?
Abdominal lump, sir.
Lump. I don't know which lump. Which lump it is? You want to say enlarged liver?
No, sir. Splenomegaly, sir.
Splenomegaly. Acha. Oh, sorry. Okay. So, but remember, it is usually in the third last female or third last female usually occur in a family which is prone to develop the, if there are multiple female, you should ask about that. NCPP have some relation with female and in a family.
Yes, sir.
Anybody would like to ask it? Anand?
No,
So,
sir.
so let us go for examination.
Examination.
પૂરો હું થોડી વાર નીચે જઉં છું, ગેસ્ટ આવે છે.
हाँ सर, हाँ सर. Okay, so
Sir, general examination. I have examined patient in well-lit room with a proper exposure, verbal consent in different position as and when required. Patient is fairly built and poorly nourished, oriented to time, place, and person. Sir, temperature was normal. Pulse 86 beats per minute, regular rhythm at right side radial artery. Blood pressure 114 by 76 mmHg at right side brachial artery, and SpO2 98% on roommate. Pallor present, no icterus, clubbing, cyanosis, edema, or lymphadenopathy. No sign of any liver cell failure, sir. Abdominal examination on inspection, distension was present with centrally placed inverted umbilicus. No any scar mark, visible dilated veins, discoloration, visible pulsation, or peristalsis or hernial sites are normal, sir. On palpation, temperature is normal on palpation. Abdomen is soft, no any tenderness, guarding, or rigidity, sir. No hepatomegaly, no splenomegaly, sir. On percussion, shifting dullness is present, horseshoe dullness is present, sir. Hepatic dullness over a fifth intercostal space to right side costal margin in the right side midclavicular line, sir. On auscultation, normal bowel sound present, no arterial groove, and venous sum, sir. On the rectal examination and proctoscopy, collapsed cavity with a stool stain, yellow color, staining present, and no hemorrhoids were seen. Spine and back examination is normal. On systemic examination, respiratory system 80 per minute, bilateral clear, and air entry is present. Cardiovascular system S1 S2 present, no any murmur heard. Central nervous system, patient is conscious, oriented to time, place, and persons.
okay, go back.
to general examination slide.
Yeah, first slide of examination.
You said that patient is poorly nourished
Yes, sir.
And fairly built.
and fairly built. What do you mean by that?
Sir, built is a skeletal, and nourishment is a muscle mass, sir.
Nourishment is only muscle mass or something else also?
Muscle mass and subcutaneous tissue, sir.
Subcutaneous tissue or something specific in subcutaneous tissue.
Fat, sir.
So is it only fat and proteins or anything else you also need to look for? So you have to look for the body composition, normal. It starts with the hydration status and proteins, fat mainly, yes. Vitamins, minerals, and trace elements. Everything you have to look for. So this is just for the theoretical sake. In exam, if you if you don't write, if you write well nourished, that's fine. But if you write that it's poorly nourished, then you have to justify yourself that why you have written. Number
Yes.
one. The next slide, please.
एक मिनट एक मिनट एक just a minute.
Yes.
What about pulse? You said 86 beats per minute. What do we expect in a patient of portal hypertension? That is number one. And number two is regular rhythm and right heart rate. What do you expect in patients of portal hypertension or liver cirrhosis?
Sir, in portal hypertension or liver cirrhosis, and presenting hematemesis complaint, there may be a tachycardia.
So that is blood loss. I am talking about
Blood
portal
loss.
hypertension and cirrhosis.
Sir, tachycardia may be present because of portal hypertension lead to splenistic vasodilation, lead to decrease in the venous return, ultimately lead to decrease in cardiac output. So,
Harshal bhai,
tachycardia may be
Yes,
present.
Blood pressure, basically splanchnic, due to splanchnic vasodilation, more of the blood gets into splanchnic circulation. So systemic hypertension would occur in this patient.
Yes, sir.
so most of the time what you see is a bradycardia with a increased dilated pulse pressure. The
Yes.
systolic diastolic difference is more what you classically say as a water hammer pulse, right?
Yes, sir.
Right. Okay. We have Hiral also. Hiral, you can also ask questions, please. Jitendra, please. Okay, Pelar, present.
See,
Satyam,
you say
can you
patient.
elaborate more what signs of liver failure you have evaluated?
Sir, sign of liver failure, like, sir, feta hepaticus, sir, sign of, sir, xanthelasma, sir, sir, palmarisma, sir.
સત્યમ
Yes,
સત્યમ
sir.
પહેલા આપણે સર્જન ઓળખી શકે એવી સાઇન બોલવાની, પછી ફિઝિશિયન ઓળખી શકે એવી સાઇન બોલવાની ભાઈ.
Yes, sir. Palmarisma, sir, and spider nevi, bilateral
You start
gynecomastia.
from, see, you always start from head to toe so that you don't miss anything.
Yes, sir.
You always go methodical, right?
Yes, sir. So from sir head, like, sir, alopecia, sir, and sir, on face, sir, feta hepaticus, xanthelasma, parotid swelling, sir, so palmarisma,
You say
spider nevi.
fetal hepaticus. What is the smell actually? Can you tell me how it how what is the smell? Have you ever
Fruity.
smelled a patient?
No, sir, I haven't smelled. Musty smell, musty.
I don't know. Harshal, I think it's a fruity smell, but I think gastroentero people would be in a
Sweet
better
musty
position.
order.
A
Sweet
little bit,
musty
sir,
order. That is what
slightly
they have.
ammoniacal kind of taste, ammoniacal kind of smell. You will find it in OPD when patient is sitting very close to you, particularly in hepatic encephalopathy patient. In mild patient, we don't much find it. It's a slightly different than fruity. I think difficult to elaborate, but if you have ever any alkaline solution of ammonia, if you smell, it's something like that.
What the books describe is sweet musty odor, just like of a dead rat.
Yes, sir.
Yes.
Rest is, sir, spider nevi, palmarisma, coilonychia, whitish discoloration of nails, sir, and liponychia, and sir, bilateral gynecomastia, sir, and sir, caput medusa, sir, axillary and pubic hair loss, bilateral pedal edema may be there, sir.
Do you have the picture of the patient?
Sir, I don't have any pictures, sir.
See, you said that patient is poorly nourished.
Yes,
So
sir.
are there any signs of hyperproteinemia on general examination?
Yes, sir.
Which one?
Some mid-arm circumference is reduced, sir.
अरे
More
किरीट
com
भाई पूछे थे कि what are the signs of hypoproteinemia you see in this patient? You said poorly nourished, so he's asking if there is any features in this patient that tells you that he's hypoalbuminic.
Ascites, sir.
ascites
Okay,
is
1 second. Second,
okay. Second, bolo.
Bilateral pedal edema can be sign of hypoalbuminemia, but patient is not having bilateral pedal edema, sir.
What else you should look for? Changes in the nails.
Leukonychia, sir. But patient is not having leukonychia, sir.
Sparse hair.
Poorly nourished means there is a loss of subq fat also. So what will be the changes in the lower limbs?
Lean and sir,
Thin and shiny skin, they
thin
can
and
be
shiny
loss of
skin.
hair or sparse hair or loss of hairs.
Yes, sir.
See, when you are describing the general examination and then you have already committed that this is poorly nourished, then you have to mention all these things to justify your finding.
Yes, sir.
and you, Biju के?
You said in percussion that there is a shifting dullness as well as horseshoe dullness. Is
Yes,
it
sir.
possible both to have?
Yes, sir.
See, there are gradings of ascites. So, what are the gradings? The mild, moderate, and severe. So, which signs appear in mild ascites? Which sign appears in moderate? Which signs appear in gross ascites?
Sir, in mild ascites, puddle sign will be positive. Sir, in case of moderate ascites, horseshoe dullness and shifting dullness will be present. And sir, in case of severe ascites, fluid thrill will be present, sir.
So, have you elicit the horseshoe dullness?
Yes, sir.
अरे how do you elicit? Tell the technique.
Yes, sir.
Sir is asking how do you elicit horseshoe dullness?
Yes, sir. Sir, asking patient to lie in supine position. I will start percussion at the umbilicus level. At the umbilicus level, starting from the umbilicus, going laterally on right side or left side, whichever side.
It is not started at the umbilicus. Hello.
Yes, sir.
See, percussion always starts whenever you are looking for ascites specifically,
Yes,
and
sir.
you are saying that you want to elicit the horseshoe dullness.
Yes,
So,
sir.
percussion starts where?
Sir, from
You
the
have written here that patient is also having shifting dullness. So, this
yes,
is a
sir.
mild to moderate. So, when you start percussing at the umbilicus, what problem you might face? See, there can be dullness even at the umbilicus level also. And since you don't have the picture of the patient, we don't know what is the size of the abdomen. So always in for ascites percussion, you always have to start percussing from the epigastric region.
Okay, sir.
If at all there is a significant or severe ascites, then also there is a zone in the epigastric region where you can find not that there is not going to be dullness. So there is going to be some tympanic knot. You start from the midline, You start percussing from the midline. The point where you first find the dullness, that is the point you mark. And
Yes,
then
sir.
you start doing from above downwards on all the quadrants.
Yes,
And
sir.
then you make a line of all the points, then you will be able to make out whether there is a horseshoe dullness or not. And what do you mean by horseshoe dullness?
Sir, in horseshoe dullness, when the patient is lying supine, the fluid is collected in the lower part because of the gravity, sir. Sir, the floating bowels will cover near the umbilicus region, will give a tympanic note, and the peripheral fluid collection, which give a dull notes.
Just like a horseshoe shape. And then
Yes, sir.
progressively it will reach up to the umbilicus also.
Yes, sir.
And have you elicit the shifting dullness?
Uh, uh, So starting from the umbilicus going laterally, when the point mark the point where the tympanic note is converted to dull, then ask the patient to shift on the opposite side and wait for 1 to 2 minutes to let the fluid to settle down, and then percuss again, which is a resonant.
So initially there was a dull knot which is shifted now to resonant knot, so that you can say that the fluid has shifted.
Yes, sir.
That indicates moderate ascites. And what
Moderate
about the fluid thrill? How will you elicit the fluid thrill?
Sir, I will ask the assistant to keep the hand in the midline firmly, and I will tap the abdomen from the one side and feel the thrill on the opposite hand, on the opposite side.
What is Staniol's sign?
Don't know, sir.
Suppose if the patient is having pelvic mass or a huge ovarian cyst, how you can differentiate a huge ovarian cyst from ascites?
Uh,
On clinical examination first.
Sir, keeping
Will
a
there be any change in inspection?
sir, umbilicus will be diverted upwards, sir.
Umbilicus will be shifted upward or it will be pushed upwards due to any mass that arises from the pelvis.
Yes, sir.
Right. Well, in case of ascites, it is going to be transversely stretched, or what we typically call a smiling umbilicus.
Smiling umbilicus. Yes, sir.
Is it smiling in this case?
No, sir.
Why not?
Nothing, he has not put up any picture, so it's difficult to say.
Yes, sir. Yes, sir. That's why it is very difficult. Actually, you should have put the picture.
કિરીટભાઈ, this is the problem. એ લોકો સાહેબને સ્લાઇડ મોકલાવે, સાહેબ રાતના 12 વાગે બી સ્લાઇડ ચેક કરીને કહે કે ભાઈ ફોટા મૂકજો, પણ એ નહીં મૂકવાના. શું કરવાનું સાહેબ, બોલો.
As I said in day before yesterday's lectures, this is only stepping stone. There is no importance of practical exam. You have to just pass. Everything is on MCQ. That's all right. Why you are not said about spleen in percussion?
So,
it's not important. Spleen is not palpable?
Spleen is not palpable, sir.
So that means it is normal size?
Cannot comment upon because of...
if you do percussion, you may be able to comment. Why you cannot comment?
Because of ascites, sir.
No, F1 is ascites. Anything else? Will it be enlarged spleen or not? Can it be enlarged spleen?
It can be, sir.
How?
Portal hypertension will lead to splenomegaly.
But it is not palpable. Which book do you read for practical exam, Satyam?
S. Das, sir.
S. Das. Is there anything word like this, that spleen become palpable only after it enlarges 2.5 times? Right?
Yes.
So
Yes,
your answer should be in exam is that, sir, before it becomes palpable, it has to be twice the size. So there can be non-palpable enlarged spleen. And
Yes, sir.
sometimes by percussion you may judge. Not always, I agree, and at level, but theory you should know that percussion is important even in non-enlarged spleen. So
Yes.
liver is palpable,
Liver is not palpable, but normal in
but
span.
so
Normal in span, sir.
normal. The liver span is normal according to, it is not pushed up or like that.
Sir, starting from fifth intercostal space,
No, I'm asking, is it pushed up or not?
it can be pushed up because of
Can in this patient? There is theory that part of it. In this patient, is it pushed up or not according to your percussion?
no, sir.
It is not. Why not?
Sir, the percussion is started from fifth intercostal space, so it's normal
Exactly, sir. The upper margin of
margin of the
percussion is
fifth
at
intercostal.
the normal liver side, so it is not pushed up. These are the very trivial things, but you should know what you are talking about.
Yes,
So, is the liver shrunken or normal?
the liver is normal, sir.
Normal. Why do you say it is normal?
The liver span is normal, sir.
That is what important. It is non-palpable liver, but that's why importance of percussion in portal hypertension. You should keep it in mind,
Yes.
right? Why
Yes.
there are various tests like a shifting dullness, horseshoe dullness, fluid thrill? Why so? Why there are different and puddle sign we don't do it?
So to grade the ascites.
Yes. So certain test can be elicited. It depends upon the amount of ascites. Which is the best way to find out the minimum ascites apart from puddle, which is not possible to do.
Shifting dullness, sir.
Shifting dullness. Do you understand?
Yes.
So if the shifting dullness is present, will there be a fluid thrill?
No, sir.
So when will you do fluid thrill?
In case of severe ascites.
Severely gross ascites.
Gross ascites.
Gross ascites.
Yes, sir.
You know why there is ascites in such patients? Cause of ascites, and predominantly patient has the symptoms of ascites. So what may be the cause for ascites in this patient?
Sir, ascites maybe due
કિરીટભાઈ પૂછવું હોય તો પૂછજો આ તો કોઈ પૂછતું એટલે આઈ એમ જસ્ટ સોરી
sir,
No, no, sir, please, sir, please.
હા
one may be the reason bowel wall edema, which may lead to
ઓ
fluid
ભાઈ
loss, and
what we are talking of
ascites, sir.
and cause નહીં નહીં disease કયો કેસ કયો છે
Portal hypertension, sir.
તેમાં બોવેલ ઇડીમા ક્યાં primarily આવે
Splanchnic vasodilatation because of.
અરે યાર that is the last what
Yes.
is the first if you say that first there will be
Portal
lot of problem.
hypertension.
How much bowel edema is needed for a increase in ascites? How does the peritoneal fluid get absorbed?
Sir, via the lymphatic.
What will it lead to bowel edema? The things which are rare should be spoken rarely.
Yes, sir.
Bowel edema is the rather, I would say, last cause. You want to say the peritoneal fluid is absorbed by bowel?
No, sir.
It is by peritoneal surface.
Surface, yes.
Right? So bowel edema, it may be secondary to ascites, but it will cause ascites rarely. What is the common cause of ascites? I knew that you know, don't read these things. Consider it Herschel's domain. Am I right, or sir?
So because of
Yes.
a back pressure created by the portal hypertension, sir.
Yes, one is a back pressure. Agreed. What else? There are in book, if you read anticipating such question, there is a list 1, 2, 3, 4, 5, something like that.
Yes, sir.
And it should be an undergraduate question, ideally speaking.
Yes. Another
And
one
you
is
are supposed to know that because it will help to, because the question will come, how will you decrease or control the ascites? If you know the cause, you will be able to tell it. Tell the causes.
sir, another one is
Yes, Harshal. Satyam, let him speak. Harshal, you were saying? Yes.
Particularly
there
in
is-
your patient.
yes,
there
sir.
is both. There is
Hypoalbuminemia, which lead to ascites, sir.
Yes, there is also another thing. There is actual increase in splanchnic blood flow. So there is increased production of the peritoneal fluid, along with reduced absorption, along with hypoalbuminemia. So there are multiple factors.
Yes, sir.
Dr. Anand Thakkar has joined. Anand bhai, તમારે બી કઈ પૂછવું હોય તો you can ask.
I'm thoroughly enjoying this academic fiesta, and I will definitely contribute where I think I would make a difference. But generally, you guys are definitely better teachers, and the way you detail these causes, I'm afraid if I was one of the students trying to answer these questions, I would miserably fail. But I'm happy to be here, and I'll contribute whatever best I feel I can. Thank you.
Why you do per rectal examination and proctoscopy in these patients?
Sir, to look for piles. And sir, yes, piles.
Only piles or something else also?
Sir, as, patient is not complaining of melena, but I have to confirm
How you will confirm?
by the color of stool, which is a tarry black in color in case of melena, sir.
Black tarry sticky stool. When you do per rectal examination and when you take out your finger, you should always look for whether there is any black stool or melena is there or not.
Yes, sir.
So that is number one. And you have to look for the piles. Why you should look for the piles?
Because of portosystemic connection, there will be a piles formation. Rectal varices, sir.
So there can be fresh bleeding also from
Yes,
that
sir.
pile.
Yes, sir.
Kirit, we had covered that part.
Okay, I didn't know, sir.
You were not
joined.
there. Anyway, did you say anything
Yeah.
about estrogen, Satyam?
Sorry, sir.
Any relation of estrogen with ascites?
Sir, sorry, sir, I don't know, sir.
That is again because of the synthesis of destruction of estrogen is done by liver, where the circulating estrogen and other corticosteroid increases contribute to ascites. Also keep that thing in mind. Again, sometimes cirrhosis will cause multiple nodules compressing over the even not only vein but the lymphatics also. That is also one of the reason for a oozing and the presence of ascites.
Yes,
Right?
sir.
But the
Yes.
most important is hypovolemia. Why?
Hypovolemia lead to hemoconcentration will lead to increase in hydrostatic pressure.
Sorry. Hemoconcentration. Hypoalbuminemia will lead to hemoconcentration.
Sorry, hypovolemia symptom. Sorry, sir.
Then I'm talking of hypoalbuminemia.
Albuminemia. So hypoalbuminemia reduce in colloid oncotic pressure, which lead to
Okay, right. But why there is hypoalbuminemia?
because of decreased production by the liver, sir.
Yes, that is the main reason. You should be able to tell. Please continue.
Also, the estrogens sometimes lead to small vessel dilatation, and that contributes to the telangiectasias in the small bowel, which may also lead to bleeding from the gut. I mean, it is not always melena, it is not always frank blood. It can be altered maroon, various colored blood, because the small bowel also develops ectatic blood vessels secondary to portal hypertension. In that, estrogens may contribute by dilating those small vessels and making them more fragile. There is generally an increased capillary fragility as a result of liver failure, irrespective of the platelet count. So also these vessels tend to ooze and increases the incidence of bleeding in the tract. So it is hematochezia, not necessarily fresh blood, not necessarily melena all the time. So the finger in the rectum will tell you a lot of things.
Yes, sir.
Satyam,
Can I make one suggestion?
Yes,
That,
yes, sir.
let us go back to main subject of management, because with due respect, we are spending lots of time here, but management is equally important.
Sir, for them to come to the management means they will pass the exam. That is more very important, sir. Sir, one last question. Satyam,
Yes.
we came across a multiple terminology, as Dr. Anand Kakkar and Sir said, hematochezia, melena, bleeding PR, So what all these different terminologies mean clinically when we speak for a patient? What is
Sir,
the difference between bleeding PR, melena, hematochezia?
yes, sir. Melena is a digested blood, most probably from the upper GI system, which lead to digestion of the blood and coming out as a black tarry stool. Hematochezia, which is undigested blood, which is coming from the lower GI. And sir, bleeding per rectum is a fresh bleed.
Bleeding PL can be various colored. Hematochezia is fresh, you're right. And one important word is acid hematine when you say
Acid hematine.
when you say melena, because in the presence of HCl only it will become black. But if there is blood in the small bowel, then it will be digested, not with acid hematine, but with other digestive enzymes present in the small gut. So they will come out as maroon or various different colors. So it's altered blood. So it can be melena, it can be altered blood or hematochezia, depending upon where it is bleeding and what is acting on it.
Yes.
And Satyam, just one more thing. Suppose if you find a patient with fresh red blood per rectum, will you surely say that it is from lower GI only?
No, sir.
Why?
It can be from a profuse bleed can, in case of increased GI motility, profuse blood, which can be present as a fresh blood.
Yes. And will you, melena, what does it signify? Melena means blood has stayed into the gastrointestinal tract for 14 hours.
14.
Cause
Yes.
can be, it can be from anywhere. It can be from esophagus, stomach, even duodenum, proximal jejunum. 14 hours is the time.
Yes.
Satyam, I would like to emphasize one point. You said per rectal examination and proctoscopy, no any hemorrhoid seen.
Yes.
Right. Actually, it should be there. It's a normal piles. And probably you wanted to convey whether the rectal varices was there or not. That should be the message if you are suspecting portal hypertension and ascites. So my question goes, how do you differentiate internal hemorrhoids versus rectal varices?
Sir, rectal varices will be strict. One is location. The rectal varices will be at haphazard location, not probably be, at 370 loc, which is a primary cushion, which will be the piles. And sir, the appearance varices will be streaky, tortuous, dilated veins, where the hemorrhoids will be a mucosal outpouching.
Okay, it is more than 4 centimeter rectal varices will be there. It doesn't follow 3, 7, 11, the classical. So the message should be straightforward. There is no rectal varices.
Yes, sir.
Okay.
Sir, anything else left out? We will go for diagnosis. Okay. Anyway, Saib, I don't know. So Satyam, what is your diagnosis?
There are so many things we can
Yes,
still
please,
discuss,
sir.
but
Please,
let
sir.
us go further. But what we wanted to convey is that it is not everything about shunt or endoscopy. You must reach that part that your concepts about the portal hypertension should be very clear. You
Yes, sir.
understand?
Yes, sir.
And you should know the etiopathology, which is very important for each cause. Why there is ascites, why there is hematemesis, why there is a liver maybe enlarged, maybe shrunken, why there is no splenomegaly in this case, why usually you find a splenomegaly. These are the points you should be able to tell. Then only the examiner will come to the part which is management. Okay, please.
Yes. Sir, summary. 30-year-old male provisional diagnosis, sir. 30-year-old male chronic alcoholic patient presented with abdominal distension since 1 year with acute episode of hematemesis for 1 day without jaundice, melena, simulation in past or an intervention with ascites without icterus or organomegaly. Provisional diagnosis, sir. Hematemesis with ascites most probably due to portal hypertension and which may be due to alcoholic liver disease, sir. Should I read
You
blood?
did not put any differential diagnosis.
Is it required, Satyam?
Yes, sir.
You can say about differential diagnosis.
So one can be uh, uh, non-cirrhotic portal fibrosis.
Go ahead, go ahead. Whatever comes in your mind, it has to be differential. So it's not necessary. It should fit with the diagnosis.
So basically, you say some kind of liver pathology. The
Yes,
cause
sir.
may be different.
Difference.
Satyam?
Yes, sir. So I would like a liver pathology, but I would like to confirm with further investigation.
Yes, you should say that it may be alcoholic liver disease,
Yes.
maybe some pathology, maybe NCPF, maybe EHPO, but my provisional is it is similar with a chronic alcoholic liver disease.
Yes, sir.
So, okay, then how will you investigate this patient?
Sir, routine blood investigation like whole blood count, sir, liver function test, renal function test, coagulation.
Don't just say the names, just what do you expect and what if something else comes? For example, what do you expect in liver function?
Sir, I expected, sir, normal bilirubin profile, but there may be a increase in SGPT or enzymatic liver enzyme can be raised, sir, and reduce in albumin, protein albumin.
Anything else? That is part and parcel of liver function.
Coagulation profile.
Before that, before coagulation profile, the essential signatures in the LFT are not mentioned here. The signature is SGOT and GGTP. Because you don't know when did this guy stop drinking, right?
Yes, sir.
So if he has not stopped drinking, you will see that signature in GGTP and SGOT, SGPT ratio. So the SGOT should be at least a time and a half of SGPT or even more.
Yes.
Got it, Satyam?
Yes, sir. Yes, got it.
Okay, anything else?
Insert liver function for the
Okay, no, so blood reports then.
Blood report and sir, radiological investigation like ultrasonography.
So what do you want to see in ultrasonography?
Sir, I would like to see a characteristic ecotexture of spleen and liver. Sir,
First of all, see the amount of fluid. That is very important.
Yes, sir.
How much ascites is probably one of the most important things. Then,
and then, sir, ecotexture of spleen, ecotexture of liver, portal vein. Is there any collateral form, portal vein diameter?
Why would you want to see the ecotexture of the spleen?
Sir,
There is nothing there.
Altered ecotexture maybe in case of
In spleen?
Splenomegaly.
Maybe a megaly, but not ecotexture. Size, yes.
Yes, sir. Size.
so what are you more? Is it the size of the spleen that is important, or something else when it comes to spleen? When it comes to spleen, huh?
Size of spleen is important, sir.
Oh, nothing else when it comes to portal hypertension.
Splenic vein.
The ascite
Size of
is
splenic vein.
important. Anything else you want to look for?
Splenic vein size.
Splenic vein, sir. Splenic vein and sir collateral.
Why?
Splenic vein diameter or thrombosis, sir, which may lead to enlargement of spleen, sir. And collaterals formation, sir, to look for collaterals.
In this patient particularly, if you are talking, the platelet counts are normal, essentially.
Yes,
and
sir.
which indirectly tells you that there isn't, and you said no organomegaly as well. So the size of the splenic vein and the collaterals around the lesser sac as well as in the perisplenic area, might be shunting the back pressure from the portal vein into the splenic vein through these varices, and might more likely lead to this patient developing encephalopathy instead of splenomegaly. So portal hypertension may have a variety of manifestations, both when you see it radiologically as well as clinically. So all those things may need to be woven together.
Yes.
Right, and don't forget the term hypersplenism, which we see in such
Hypersplenism.
patients.
Yes, sir.
So better you should splenoportal Doppler. You want to look for the size of the splenic vein, portal vein, as well as whether is there any thrombosis or not. And the most important thing is the direction of the blood flow from the portal vein to the liver,
liver.
whether it is hepatopetal
Or hepatofugal.
or not.
Yes, sir.
Hepatofugal, right? Okay.
Yes, sir.
Also, there is a very fine point here which may matter when it comes to managing this patient. And if you have not mentioned this in your investigation, then it might come back to haunt you later, is the size of the left renal vein.
Yes, sir.
We'll just complete the
Why,
investigation.
Satyam, why sir has asked about size of left renal vein?
Sir, there is a formation of linorenal collaterals formation. And sir, maybe in a future we need a shunt, which may require.
Yeah. Yes.
No, not just that. In case if you are doing a liver transplant for this guy, because he has decompensated chronic liver disease, there is no organomegaly, so the liver is shrunken. So shrunken liver having massive ascites and esophageal varices that are bleeding, he's symptomatic. He is hypoalbuminemia. Most likely he's going to end up in liver transplant. But
yes,
if you look at his portal flow, he might not have a great forward portal flow. In case if he has a huge splenorenal shunt and the left renal vein is dilated, then you will have a paucity of forward portal flow when you reperfuse this liver. And at that point, if you have not identified the linorenal shunts, and you will have no way to give him adequate portal flow unless you ligate the left renal vein.
Yes.
So in the various radiological parameters that the surgeon should know while going into transplant are these things. Whether he has celiac artery stenosis, whether his size of the left portal vein, the topographic locations, and the significance of the collaterals as a result of portal hypertension. This all go into how you are going to manage this patient eventually surgically, because at the end of the day, you are giving a surgical exam.
Yes, sir.
My point is, liver transplant is the last stage. Before that, there are so many things can be done, even the
I'm
operation.
sorry.
So, what he's saying is the last thing, and very few percentage of portal hypertension you see liver transplant. He has a special liking for liver transplant, so he's mentioned. But there are so many other things you will go before the final stage will come.
Yes, sir. Yes, sir. Yes, sir. Satyam, so this is a good point to remember. Okay, after you've done an ultrasonography, anything else you would like to say in this patient?
What is fibroscan?
Elastography, sir. Elastography scan to look for a grade of liver cirrhosis, sir.
So
elastography and fibroscan are different investigations. Elastography is done using an ultrasound. Fibroscan is doing fibroscan, and they use different parameters. One is more validated than the others. I would not trust elastography, but fibro I would vouch by it. So they are not the same thing.
So, Dr. Anand, can you just elaborate a little on both?
So liver elastography is done using the regular ultrasound machines that we have in our radiology departments, and they mention the same parameters, the KPA and the CAP values, and fibroscan again uses the same technology, but the machines and the calibration of those the waves that return back to the probe are better calibrated. Now, if you ask me the technological difference, I wouldn't know. But if I have a KPA value of say 17 in a fibroscan, I would say that he's grade 4 fibrosis and about to end up in cirrhosis. And I can correlate that with the degree of portal hypertension, but I can't say the same with elastography. Elastography is not as validated as fibroscan.
But basically, the technology is same, and that is a different the elasticity or the fibrosis in the liver.
Is there anything like the fibroscan is done by a gastroenterologist? Harshal?
Harshal?
What, sir?
Is that the fibroscan is done by gastroenterologists most of the time?
Sir, anybody can do it. It's a simple test.
But that's what I have observed. Because,
Yes.
and yes, maybe that's the one more reason that it is right. Uh,
Yeah.
Satyam, there is a one more point I just want to know. Just go back for a 1 minute. Apurva, if it's okay.
Sir, barabar, please.
Just go back because that's it's a one more. Yes, you have a total protein is 7.54 and albumin is 1.77. So what else is there? And what does it mean?
Globulin, sir.
But what does it mean?
Uh,
Have you said anything about ratio?
yes, sir. Albumin globulin ratio, which is
Uh,
reverse in this case.
What is it? Not
Uh,
done.
not done, sir.
Oh, that is impossible, yeah. It must have been. It suggests. So this is another important point you should always remember. Ratio is important.
Yes, sir.
What does it suggest in this patient? It must be reversed. Totally 7.5 and albumin is only 1.77. What does it suggest?
Liver function is reduced, sir.
No, it's not like that.
The globulin વધી ગયો છે એમ પૂછે છે શું કામ?
Sir, because of globulin is produced by the reticular endothelial system, so which is normal in production, and albumin is reduced because of the liver disease. So it Hg ratio
Significantly
will be
reduced. I don't know the cause. Maybe.
See, the funny part about this number in particular, and I want to point out one thing here, is that if you take out 1.77 from 7.54, you have a very high amount of globulin.
That's very surprising.
Very surprising. And this commonly confuses people. And if you measure the globulin, it is very high. And then you would want to do autoimmune parameters because you want to know why there is so much globulin here. And routinely, because we have an etiology here, the guy has been drinking. So most likely his ANA, AMA, ANCA, LKMA, all are going to come negative. But the one number that will come positive is IgG.
Yes.
So his IgG will come very high, and it is not uncommon for autoimmune diseases to have just IgG positive because we have not learned about all the potential antibodies that can go and hurt the liver. So that always raises a possibility that is it a combination of etiologies, he has been drinking yet he also has autoimmunity versus something else. And I mean, ideally it should not be asked for a general surgery exam. It should be asked for hepatology. It will not be asked. But generally the one line that I want to tell is that all end-stage liver disease patients will have an elevated IgG. It does not hint at autoimmunity.
But
So
when there
usually
is such a reverse ratio, always think of that
Yes.
liver is quite, and always a possibility of autoimmune part because
Yes.
so much of globulin production is not. Yeah. Please
so
carry
usually in
on.
any case of cirrhosis due to any etiology, there is some increase in serum total globulin. But if it is so
Yes.
much raised, as in this case, we should get an autoimmune workup. Another thing is when we find anybody with history of alcohol and with who is having cirrhosis, we usually assume that it is due to alcohol. But if you see, many people drink alcohol even in binge amount. Only we see 10% of people develop alcoholic liver disease. So if those 10% are okay due to that, but we have to also rule out the common causes associated like viral etiology, and in this kind of case also NASH, also dietary history, HbA1c, lipid profile, and we should also rule out this autoimmune thing if we are having such odd values. So just to make sure that there are no just as sir mentioned, double etiology.
Yes.
Yeah, also Wilson's, also hemochromatosis.
Yes.
You have to do iron studies, you have to do copper studies, you have to do all the chronic liver disease workup has to be entirely done for any cirrhotic.
But it will be more of a DM or MCH level, not here, I think. It will be very difficult for everybody. Yes, please continue. Where were you?
Sir, so what about endoscopy?
Yeah.
Any after ultrasonography, Satyam?
Yes, sir.
Has this patient undergone endoscopy?
Sir, patient.
Okay, patient has gone or not? Would you advise endoscopy or not?
I would advise, sir.
So you will do endoscopy after all this investigation or
No,
after
sir.
essential investigation?
After essential investigation, I will go with the
Why?
endoscopy within 12 hours.
Why?
To look for the to confirm the diagnosis which is varicose bleed, and if it is varicose, then we can go with endoscopic intervention.
Okay. Right.
One thing I wanted to add here, sir, is that practically, and I don't know from the theoretical or exam perspective, you guys are champions there. But if an ultrasound shows a shrunken, altered echo texture, and it shows a dilated portal vein and others telltale signs and stigmata of portal hypertension, I wouldn't do a fibroscan or an elastography. It has no value. It does not add. It just spends your money. And then
Okay.
you are going to do a endoscopy anyway, and you're going to see
Yeah.
portal hypertension to
Yes,
whatever
that's what I would
extent.
say. Before, that's what I was elasto, fibro, all this before that in patient is bleeding. Even when in exam, you must say scopy before anything else, which is very
Yes.
important because it's an emergency procedure.
Emergency. Yes, sir. Yes, sir.
Yes.
Harshal?
Yes.
Yeah. So was an endoscopy done? And
So,
why was it done? Let us say, just to complete the.
for in my patient,
Yeah, obviously.
sir, sir, endoscopy is done, sir.
Yes.
So what do you look for, and what are the things that you can do, and what are the things you should not do?
Sir, to look for varices. And in case of varices, we go with band ligation, sir.
Not every.
And to look
If it's
for
bleeding, yes. If it is those red whale signs, yes. If they are large, yes. But grade 1 or 2 varices that are not bleeding, you won't.
and to also look for stomach gastric varices, and to look for any ulcer or sign of gastritis, which may be presentation in case of hematemesis.
Portal hypertensive gastropathy.
For hypertensive gastropathy, yes, sir.
So what do you do for gastro? See, you said bending for esophageal varices. What do you do for gastric varices?
Sir,
Sorry, fundic varices.
glue injection of glue, sir.
Okay, and how do you classify? Harshal is already there. How do you classify esophageal varices?
Sir, there is a 3 grade in grade 1, linear streak column of dilated veins, and grade 2, sir, there is a tortuous dilated vein with occluding less than 1/3 of diameter of lumen, and sir, grade 3, which is large, which occluding the more than 1/3 diameter of the lumen, sir.
Okay, and what is the term varix on varix means?
Varix on varix means a small red lesion over the dilated veins.
Okay, you said bending, right? But if the varices are not that big, you are not able to suck it in. What do you do?
Sclerotherapy, sir.
What agents are you using?
Sodium tetradecyl sulfate, sir.
Only one? Any other molecules available in the market?
Polidocanol.
Polidocanol, yes, sir.
So what is the percentage available in the market? How do you inject, and what are the needle gauges you use for it?
Sir, I don't know, sir.
Satyam, you investigate all these blood reports and radiology, and what is your goal?
Goal is to primary goal is to actively manage the patient, which is hematemesis, and then to diagnose the cause of portal hypertension.
That is one. What about the liver itself?
Which is compensated or decompensated, or
What are the criteria? What are the different scoring system that you want to confirm?
By the scoring system, child-Cook score. Another one is a MELD scoring system, sir.
So what is the importance of child-Cook score?
Sir, by child-Cook score, we can classify patient in mildly severe disease, moderately severe disease, and very severe disease, and then we can proceed for the plan of management, like liver transplantation or conservative management.
So exactly. So how your overall management will change, that will depend upon the scoring system, right?
Yes, sir.
So what is the score in your patient that you should have actually mentioned?
Yes, sir. Child book score is, sir, 8, sir.
How it?
How did you
Sir,
calculate?
Sir, hepatic encephalopathy, no hepatic encephalopathy, which gives it score 1. Sir, bilirubin, which is a total bilirubin, which is less than 2, 1.2 value, actual value of 1.2, which is less than 2, score gives it 1. And then, sir, ascites, which is a moderate ascites, which gives it score 2. And
No, that's 3. No mild and moderate. Moderate is 3. CTP score.
sorry, sir. Yes, sir. And sir,
Can we?
yes, sir.
Yes, sir. You are saying something. Rupesh bhai, તમે શું કીધું?
Yes, can we go back to gastroscopy, which is very important? If you know GOV1, GOV2, IGV1, and IGV2, do you know what is the difference between all 4?
No, sir.
સાહેબ, 2 મિનિટ સાહેબ, આ એનો ક્વેશ્ચનનો આન્સર આપી દે. Just 2 minutes, sir.
Okay.
સત્યમ,
Yes,
કિરીટભાઈના
sir.
ક્વેશ્ચનનો આન્સર આપી દે.
Yes, sir. Last point, which is prothrombin time, which is 16, which is elevated but less than 4, which give it score 1. So, sir,
So it can
final
be
score is 9,
child,
sir. 9, sir.
is it child A, B or C?
Sir, it is child B, sir.
Symptomatic or asymptomatic?
Symptomatic, sir. Symptomatic child B, sir.
So that is very
INR was
important.
1.77, Kenny. INR was 1.77, right? You said? I don't
Yeah.
remember that.
Yes, sir.
So 1.77, so less than 1.7, 1.7 to 2.3 and greater than 2.3. So 1.77 and the prothrombin time also, if you use instead of INR, it will be 4 seconds or more, less than 4 seconds. So 4, so that's 2 points. And albumin 1.77 is also 3 points. So 3 for ascites, 3 for albumin, 2 for INR or prothrombin time, whichever you use, and 1 for bili, 1 for encephalopathy, which makes it 10 CTPC.
Yes, sir, 10. You get it, Satyam?
Yes, sir. Get it, sir.
See, if you don't get it, please ask. Even because we don't get it. You have to ask Anand.
Yeah. See, prothrombin time less than 4 seconds is 1. 4 to 6 seconds above control is 2. Greater than 6 is 3. If you want to use INR instead of prothrombin time, it is less than 1.7 or 1.7 to 2.3 or greater than 2.3. So it's 1.77 is 2. And INR is more, used. I can't say whether it is more reliable or not. But clearly 3 for albumin and 3 for this, and so 9 to 10, whatever.
Yes, sir.
Yeah. Is there a difference? Like suppose you end up with B9 or C10. Does it really make a big difference to the patient?
Yes, sir. Score 10 will classify as a severe liver disease.
And B9?
9 is a moderate.
So what would it really make a C change in terms of your recommendation to the patient? Or am I going too far? We can come to that later.
Yes, sir.
So because it is 9, we go back to Rupesh bhai.
Okay, my question was, we still have to spend some time in gastroscopy. Now, in gastroscopy, there are 3-4 terms, which is GOV1, GOV2, IGV1, and IGV2. Do you know anything about this?
No, sir.
Or I will tell you. Okay. GOV1 means gastroesophageal varices. And if it is 1, then it is basically esophagus and lesser. But if it is GOV2, then it is this esophagus and mainly fundal side of varices. And IVG1 means only intragastric varices. There is no fundal there is no esophageal varices. And IGV2 means not fundal, nor esophagus, not on the lesser curvature, but anywhere else in the stomach. Now the question comes, during the further management, we are talking of management of the varices and further plan of surgery. Now, if it is IGV2, that means it is not possible to manage through endoscopy or anything, and you have to go for surgery. If it is GOV1 and 2 and IGV1, you can go for operation. Now, that is separate issue which we'll discuss little later on. What kind of operations and what is possible.
But I don't know. The gastroenterologist and gastrosurgeon would say most of the time, sir, nowadays endoscopy does take a lot of care of this bleeding hematemesis.
Now, can I make some comments?
Yes, sir, please.
Okay. Now, it is very clear if it is non-cirrhotic, then still the operation is much, much better. If it is cirrhotic, then there is a question. Then, of course, sclerotherapy and other things are necessary or it would be helpful. Now, with due respect, all the gastroenterologists will not like to refer the patient to a surgeon because they will continue with varices injection till the last day. And we, through our experience in last 40 years, that if it is non-cirrhotic portal hypertension and vein, if you operate well, I have seen patients, even today I can produce patients whom I operated on before 30 years, 25 years, 20 years, and they come back because the liver is good. It is only the vein which is blocked, and if you do proper bypass, results are much, much better. This is my personal opinion. But having said that, I have to blame our surgical colleagues also that not many people are into shunt surgery. And that's how they refer to, physician and they go for sclerotherapy. Anand, do you agree?
Yeah, I
Anand,
mean
you're
the
good.
shunt. No, no,
I unmuted
so
myself.
I basically shunt surgery has fallen out of favor uh, because most common cause of portal hypertension is
So,
cirrhosis,
sir,
and
so for Satyam, there is a question regarding to what we are discussing. That
sorry.
then, when it comes to pathology, how do you differentiate or how do you classify portal hypertension depending upon the cause? What are the types of portal hypertension?
Sir, portal hypertension will pre-hepatic cause, hepatic cause, and post-hepatic cause. In pre-hepatic cause, there will be splenic vein thrombosis, mesenteric vein thrombosis, extrahepatic pulmonary vein obstruction, and portal vein thrombosis, sir. Extrahepatic portal vein obstruction. And sir, hepatic causes further divided into pre-sinusoidal, sinusoidal, and post-sinusoidal. In the pre-sinusoidal, there will be non-cirrhotic portal fibrosis, sir. And sinusoidal causes, which is alcoholic cirrhosis, viral hepatitis cirrhosis, or Wilson or hemochromatosis, or post-sinusoidal is a veno-occlusive disease, sir. And post-hepatic will be a Budd-Chiari syndrome, sir.
So now the answer Dr. Rupesh Bhai and their question that how do you manage the patient depending on the classification?
I'm talking of pre-cirrhotic, which is mainly because of the portal vein either blocked there or multiple erosions and all that. So they have excellent liver function. And if it is excellent liver function, then bypass surgery is very essential, effective, and I'm repeating that I can still produce 10, 15 patients who
So
were
provided
operated
the liver
before.
function is normal, you can.
Because it.
Yes, definitely, sir. Unfortunately,
then the.
majority of the patients that we see in our practice, majority, not sir, that they are alcoholic liver disease. This is what we have routinely seen.
So
You
I
are right, sir.
agree. Now, there is a large number of patients who are young, 13 years, 15 years, and all of them are not alcoholic. And they have splenic vein obstruction, mainly with normal liver function. And that is where I am trying to point out that this is
Right,
where,
sir.
and I, with due respect, I have been operating for many years on this. There are very few physicians, they refer to me even till today, when they find that there is only esophageal varices uh, because of the block outside the liver, because of the vein block, not liver damage.
Right, sir. Right, sir. Thank you, sir. So, Satyam,
Yes, sir.
according to child-food criteria, what you have seen, the patient of liver cirrhosis with portal hypertension, right?
Yes, sir.
For to tide over the crisis, we go over for a emergency endoscopic procedure.
Yes,
Just
sir.
for the sake of completion, can we know if you don't have an endoscope, what are the tubes that we have used in history? Just for the
Sir,
sake of completion, you should
sir,
know the names at least.
yes, sir. Sangstekel Beckham tube, sir. Linton tube, sir, and Minnesota tube, sir.
Is there any chance you know the difference between these tubes?
Sir, Sangstekel Beckham tube having a two balloon with the three lumen, one balloon, gastric balloon, one esophageal balloon, and one lumen for gastric aspiration. And sir, Minnesota tube is a modification of Sangstekel Beckham tube, which having a two balloon and four lumen. Extra balloon is added for esophageal aspiration. And sir, Linton, which is an old one, which only has a esophageal balloon and three lumens. Two balloon and sorry, one balloon and only two lumens, sir.
With due respect, now nobody uses.
Sir, sir, that is what I said. This is just for the sir.
No, no,
In
I agree.
exams,
I
we are
agree.
supposed to ask, and they are supposed to know. That is why I am asking.
No, no, I agree, but at the same time, they should be very clear that it is absolutely useless now.
Sir, that is why you are there, and Dr. Anand is there, who is going to take an overview on liver transplant. I agree with you, sir. I agree with you.
But for exam purpose, they must know, sir.
Yes. For
One
exam
more
purpose,
thing
they
for
should know.
Satyam. Suppose if you are going to another center for exam, somebody asks you, where would you keep these
They will
tubes
ask.
in your ward? Where would you keep the tubes?
In trauma,
In trauma center, in the cupboard?
probably yes, sir.
अलमारी में रखोगे ट्यूब को?
No, sir. Easy access. As we have rights, RT rights to on hands.
इन ट्यूब को फ्रीजर में रखते हैं क्योंकि ये रबर की ट्यूब होती है, बहुत पुरानी टेक्नोलॉजी, इतनी सॉफ्ट मत देखो, यूज मैंने भी नहीं करी, बट हमारे हॉस्पिटल में बस एक पड़ी रहती थी. इट वाज सपोज टू बी केप्ट इन फ्रीजर, क्योंकि अदरवाइज तुम डालने की कोशिश करोगे तो ये बहुत डिफिकल्ट होती है जाने में.
The rubber
तो वो
becomes
फ्रीजर में रहती है
rigid.
तो, हाँ वो थोड़ी रिजिड रहती है तो जा सकती है. एंड यू हैव टू डू इट इन सफिशिएंट शॉर्ट टाइम कि वो ठंडी रहे और अंदर चली जाए.
Okay, sir.
So if at all you
ये
put in
सवाल
the tube,
पूछते हैं, यूज कोई नहीं करता.
Yes, sir.
if at all you put in the tube, how do you inflate, or with what do you inflate the gastric balloon, and with what do you inflate the esophageal balloon?
Sir, both balloon will be inflated with the air only, sir. Gastric balloon is a 450 cc of air, and esophageal balloon is a 40 to 60 mmHg pressure.
Marshal bhai,
યસ સર. અને આ કર્યા પછી એને સાથે ફૂલ લગાડીને રાખવું પડે.
Yes.
most of the time it has to be put through the oral cavity
Yes.
because it has 3 or 4 lumens, right? Okay.
Yes.
So now okay. Now this patient has, supposing this patient has left-sided portal hypertension, how do you treat the patient?
Sir, in case of left-sided hypertension, portal hypertension, we can go with the surgical operation, shunt surgeries, like distal sphenorenal shunt, sir.
If it is classical left-sided, then even only the splenectomy will be
Splenectomy will
sufficient.
do.
But if it is associated with the paresis and all, then linear shunt will be more effective.
Right.
So you have to
Yes.
define whether
Yes.
it is only splenic vein which is blocked and whether it is IVC which is blocked.
Yes, sir.
Satyam, could you emphasize this portal hypertension is a cirrhotic or non-cirrhotic?
So this portal hypertension in this patient is a cirrhotic portal hypertension, sir.
Cirrhotic portal hypertension. So, okay, what is the management in cirrhotic portal hypertension?
Sir, in case of cirrhosis decompensated, so we can go with the transplantation. But
Satyam, this patient has come to you,
yes,
and
sir.
he will be attached to you for his life. How will you manage? See, he is not going to be treated by any of, he cannot be cured of the disease, right?
Yes, sir.
So how will you manage this patient over the next 20 years?
Yes, sir. Sir, primarily we can go with the transjugular intravenous photosystemic shunt.
Oh.
No, that is not effective for long period. It
Yes,
is
So
a short
why
term.
do you need, so first of all, why do you need tips? Tell me, why do you need a bypass? I mean, yeah, there is nothing like any medical management of this thing. Cannot you manage the ascites with, because see, you said he has never been to a doctor, right? So first of all, सीधा ही थोड़ा tips करोगे यार. You'll do an endoscopy, you'll do a sclerotherapy or a banding. Where will you call him again? What will do it for his ascites?
Sir, we will call him after 3 months, and if there is a ascites.
I think it is 3 to 4 weeks, not 3 months.
Yes,
Arshal bhai,
earlier, so that if there are varices or anything, you can do some sclerotherapy or whatever. So initially, it is the sclerotherapy, not operation.
Yes, sir.
Operation, when I was mentioning, especially in a non-cirrhotic patient, younger patient who have normal liver and varices. So that is where you can be of great help.
so what
अच्छा
about his
आप पेशेंट
ascites?
So still he is having ascites, sir. We can treat cirrhosis by steroids, sir.
No. Not straightway steroid.
Counterproductive steroids would be. How would steroids help?
That's wrong.
Liver has a lot of reserves, right? Directly on the day one, when the patient, see, you say that the patient has ascites since 1 year, but there is no dyspnea, nothing. So that means a moderate grade ascites. What do you treat? How do you treat?
ફર્સ્ટ ઓફ ઓલ આ પેશન્ટ ઓપીડી માં આવશે, આપણે બધા ઇવેલ્યુએશન કરે. એક ટેસ્ટ હજુ બાકી છે. શું? સોનોગ્રાફી થઈ ગઈ, એન્ડોસ્કોપી થઈ ગઈ, બ્લડ ટેસ્ટ થઈ ગયા, ફાઇબ્રોસ્કેન થઈ ગયું. એક ટેસ્ટ હજુ બાકી છે. પેશન્ટ ફર્સ્ટ ટાઈમ આવ્યું છે, બરાબર?
I like the question. It's a good one.
Satyam, any idea? Prakash, what all? Arshal bhai.
તારી ચીફ કમ્પ્લેન ની ફર્સ્ટ કમ્પ્લેન કઈ છે?
Abdominal distension since.
તો which test still remains?
Please, you continue, Arshal bhai. He doesn't know.
See, ascitic tapping. આ કેસમાં you can do therapeutic plus diagnostic plus at least diagnostic, બરાબર? ચલો ascitic tapping કર્યું. કયા ટેસ્ટ એમાં મોકલશો?
Satyam,
Baseline.
supposing this patient is cirrhotic, as Arshal, we are considering, what do you expect in the reports of the routine microcytology, whatever you are sending for the ascitic fluid?
Yes, sir. Sir, in ascites there will be a reduced ascitic albumin and high protein, sir. No, low protein, sir. See,
Okay,
SAG
આના માટે
ratio.
છે ને? Yes, SAG ratio.
SAG ratio. We will assess the SAG ratio, sir.
Will it make any difference in treatment, planning, and everything?
Sir, if
basically you will like to see first thing. What will you send in ascitic fluid in any cirrhotic? First time, albumin, protein, cytology, TLC, DLC, ADA. અને જો SBP સસ્પેક્ટ કરતા હોય તો કલ્ચર. અચ્છા, સપોઝ કલ્ચર લેવું હોય તો how would you take culture sample in an ascitic fluid? You will inoculate the ascitic fluid bedside into blood culture bottle. Not that the plastic ni bottle માં આખી ભરીને મોકલાવો. Because by the time it is shifted to the microbiology lab, all the bacteria will die. It will always come negative. You should inoculate at least 20 ml or 10 ml ascitic fluid directly into blood culture bottle and immediately send it to the micro lab for culture to rule out. Suppose if it is SBP, then to have proper bacteriology. When will you say SBP? Neutrophil count more than 250. So suppose if you have TLC count of 1000 and neutrophil are 80%, so 800 are neutrophils. So that will give you diagnosis of ascites more than 250.
Yes.
One most important thing you will see, SAG ratio. Not obviously albumin protein are important, but SAG ratio. At patient serum albumin minus patient's ascitic albumin, more than or less than 1.1. More high SAG, less 1 SAG. And ascitic protein level 2.5, more than 2.5, less than 2.5. So there is in a regular cirrhotic patient without any infection, you will see high SAG, low protein ascites. So patient's ascitic albumin is significantly less than his serum albumin, along with less total protein in ascites.
Yes, sir.
આના સિવાય બીજી જે ઇટિયોલોજી હોય, સપોઝ this will help you rule out it from separate it from cardiogenic ascites, nephrogenic ascites, hypothyroidism related ascites, infective ascites, COX, pancreatic ascites. So high SAG, low protein, high SAG, high protein, and low SAG, three categories are there.
The question is, if it is clear-cut portal hypertension, there are enough variations. Liver is either, depending upon the stage, enlarged or reduced in size. And all reports are in favor of cirrhosis of liver. There is one danger. If you try to tap, there will be, you are adding infection. So that you have to be very, very careful, because infection in portal hypertension will create further complications.
Yes, sir.
One
Okay.
more question can I ask you?
Yes, sir, please. Sir.
Do you know about Budd-Chiari syndrome, and what is how do you diagnose and how do you treat?
So Budd-Chiari syndrome can be of two types, in which one is a hepatic vein thrombosis and another is a congenital inferior vena cava wave formation, which lead to in early Budd-Chiari syndrome there will be a normal liver. So the SAG in SAG ratio will be 1.1, but in early phase there will be a high protein, high SAG value. But in late phases, ultimately liver is damaged and ultimately lead to high SAG, low protein.
So basically, it is hepatic vein which is going up is either blocked or there is some pathology there.
Yes.
So there are only two ways mainly, either conservative or surgery. But surgery is very difficult but possible. And overall prognosis of confirmed case of Budd-Chiari is not that great. You're talking of 5 years, 10 years, something like that.
Yes, sir.
You have operated on few cases of Budd-Chiari, but it is not easy to manage them.
Yes, sir.
Anything else also on your side, Harshal bhai, Anand Patel?
Sir, I just would like to give a more emphasis pertaining to Rupesh sir, what he has said. Very few centers are now there who does the shunt surgery. And during our super specialty training, only we had opportunity with proximal splenorenal shunt. We had absolutely no idea with other kind of the shunt. And quite obvious now, so much of liver transplantation is being carried out. This group of the patient usually remain on endoscopic line of therapy, and then they go for liver transplant opinion. Cirrhotic portal hypertension.
Right.
I would like to second that opinion. And the reason why I'm saying this, sorry, Rupesh bhai, I'm interrupting you. I'm sorry, sir.
Yeah.
The reason why I'm saying this is that if you shunt this guy, you are going to jeopardize his transplant, because that shunt is going to be stuck in the middle of so much portal hypertension that when you reperfuse his portal vein, he will have no forward flow, and it will be impossible for you to go find the shunt and ligate it. It is going to be a bloody affair. If somebody is cirrhotic, is about to, I mean, this is the floridly decompensated, but even if somebody is like threatening to decompensate and you know that it's a matter of time where he will land up for transplant, please don't shunt him. Accept
now,
tips.
my question is, we are not debating on a different area. I'm not talking of cirrhotic liver. I'm talking of non-cirrhotic liver. There are a large number of patients with extrahepatic portal vein, which is
Yes.
blocked, and that is
Yes.
where surgery is very effective. If I tell you that we have operated more than 200 patients, you wouldn't believe, because we were
100%. I agree with you,
operating
sir.
from
Yeah.
No,
from
Rupesh bhai, you are absolutely
1982.
right, sir. Sir, unfortunately, that's what I'm telling, sir. Unfortunately, even I have been in SEAL Hospital for almost last 25 years. Majority, not majority, 99% patients we get are patients of portal hypertension because of country-made liquor.
No, that is correct. But at the same time, you still get, even I get
Yes.
even my stage, every 3 weeks, one patient coming from gastroenterologist that he's a non-cirrhotic, and please help us with surgery.
Right.
So
For
you
EHT,
have to
you're
diagnose.
100% right. Yeah.
So in that, you should not go for liver transplant. The idea is this, and believe me, I can produce at least 10 to 15 patients whom I operated before 20 years, 30 years, and they still come
So,
for
Satyam,
regular
Why
follow-up.
would
Yes, sir.
Satyam,
nobody would
looking at
question you on that, sir?
So
looking at what
I'm glad
the
that
discussion is going on, Satyam, can you tell us what are the different shunt surgeries available in the market? I mean,
Uh,
that the books have.
Sir, there is a two type of shunt surgery. One is a non-selective and another is a selective. In non-selective, there is a side to side. First one is a proximal splenorenal shunt, which is known as a Linton shunt, and another one is a side to side and side to end portocaval shunt, which is a non-selective. And in selective one, there is a Warren shunt, which is a distal splenorenal shunt. Sir.
So what
And
is the
what
problem
about
with these non-selective shunts? Sorry, sir. Su pucha,
no,
ek minute.
continue.
Su pucha.
No, let you
Okay.
continue.
So what is the problem with why do we come with selective shunts? Why not the non-selective ones? They're easy to make. You get my point, Satyam? Why
Yes,
have we converted from non-selective to selective, almost stopped doing shunts? But why have we converted non-selective to selective ones?
So most of the
sir,
time, most of the shunts are done splenectomy and the splenic vein to renal vein. That is the commonest surgery done across. What he's saying is slightly different, but that
Yes,
is
sir.
not done routinely.
Yes, sir. Sir, in non-selective shunt, we have a problem with hepatic encephalopathy, development of hepatic encephalopathy, because we divert the bowel.
Right.
Total blood
Total
blood
blood.
going
So
to liver
ultimately,
from
it's a doom
left
for the
side.
patient after maybe 10 years or so, right?
Yes.
Right.
Yes, sir.
So we go on to non-selective shunts.
Non-selective.
Okay. Rupesh, what are the non-selective shunts we do?
Sir, we have a distal splenorenal shunt, and sir, one is a left gastric to caval shunt, sir.
No, apart from that, there is two side shunt between the veins, splenic vein, not splenic vein, but the vein which is, of course, the main vein going towards the vena cava. There is one two side shunt. And second and very important shunt, which is not done now at all, is right vein of the ileum, and that you connect it with the ascending vein. And that is not that difficult, especially in a child patient where you are not getting big size of splenic vein, and to do a shunt surgery is very difficult. So in that case, renal vein, not renal vein, but right iliac fossa, you go as down as possible, dissect out the vein, distal vein is blocked, and that you connect with the ascending vein. So that is very effective, and you won't believe, but I have 10 patients operated, and they come back after 15 years, 20 years, and then we have done second shunt. So we have some 15, 20 patients where we have done two shunts, lower and later on the upper one.
Right, sir.
Yes.
So Satyam, I would like to ask one question. I think Harshal Bhai can give you the ideal answer to that. What is the role of tips when you talk about shunt surgery?
Tips is a sir bridging procedure.
Bridging for what?
If you are only going for liver transplant, that is ideal. That
Yes.
you buy time make the patient stable, and then send him for liver transplant. And then he is in a proper condition.
Sir, in case of patients on portal hypertension, whom we have done all the other measures, and patient is still not improving, and we don't have available liver transplant, and patient is waiting for the same, then tips will buy some time. Of course, it has some side effects like hepatic encephalopathy, but it will definitely reduce all sorts of portal hypertension related complications like this gastric varic bleeding and esophageal variceal bleeding if he's having recurrent those things.
Can I
The
add
biggest
something here?
problem is it will be blocked within 30 to 40% of tips are blocked within short period. Now nobody can predict when it will be blocked, and it is not that easy to insert. Some real specialist has to be there with lots of experience who can do a proper procedure.
Dr.
I
Apurva
would
bhai,
like to.
we have Khakkar sir, and we have so many PG students lying there, and they are going to listen. So I must say, Khakkar sir, you please speak something about liver transplant, the indications and current scenario.
Kirit, just give me 5 minutes. खाली वो आनंद ने पूछी लो, Dr. Anand Patel.
Yes, sir.
Rupe, anything left out in
Yes,
this
sir.
particular case?
Pachi,
the show is of Anand Khakkar only. But before he start, we'll just complete the case.
sir. Sir, he has covered many points of that pertaining to history, examinations. Only one comment was that do not give a leading questions, particularly when you do not have the idea about where the viva will go. So if they do not know, just tell them, I don't know. So he has an opportunity to get the another question.
Yes,
So one more thing is, whatever negative history you ask, you need to know why you have asked that negative history.
yes,
Only because the book has enumerated does not mean you should ask. Because the most of the viva is good that way. That is right. Dr. Anand Bhai is absolutely right. Secondly, you should know the basic treatment and basic pathophysiology treatment of ascites. See, when lesilecton, why don't you give Lasix? Why do you do lesilecton? What is the role of Dieter? What is the role of terlipressin? We haven't tested on somatostatin. I don't know if we, Arshil, do we use nowadays somatostatin or terlipressin or something?
Yes, sir. For bleeding we use.
Okay.
Only acute bleed, terlipressin will have.
Only till we do definitive treatment of varic.
That is till you do the endoscopy or something, or what?
Yes.
Okay.
Initially.
So, but you need to know what is the loading dose,
yes,
what is the maintenance dose, what are the complications that you encounter. These are the basic things which almost everybody of any age would know because they are since almost 50, 70 years. Right?
Yes.
What Dr. Anand Khakkar is now going to tell, maybe a very small group of people will know, but you need to know because in exams, even in surgery, anybody can ask anything and they are right about it.
yes, sir.
Right. So I think we have discussed. Do you want to elaborate on child book, sir? Dr. Anand Khakkar?
Yeah. See, child record PUG see, there are two scores mainly we use. One is CTP and second is MELD. And it is very important to understand that in the clinical decision making as to what direction are we going to guide this patient into, CTP has a bigger role than MELD score. Child record PUG score, A is compensated disease, B is early decompensation, C is end-stage liver disease, bad decompensation leading towards multi-organ failure, likelihood of patient going into diuretic-resistant ascites or hepatorenal syndrome and stuff like that, which will basically precipitate the need of transplant. The risk of losing life in child grade C is higher. So generally, you can say that in CTP stage B, once you are a decompensated patient, your fate is sealed. You are not going to. Eventually, you are definitely going to need a liver transplant to be able to survive a meaningful duration and quality of life. But if you are in C, then essentially means that your tail is on fire, your time is running out, and that you need to expedite in whatever way you can. So this clear definition of A, medical management, B, you need a transplant, but at the same time, you need to you have the luxury of modulating the time for transplant based on two things. One is the severity of clinical disease, and two, comorbidities. So these two factors decide the timing for transplant in B, but in C, really, it's do or die. The clock is ticking, and any later may be too late. So this is very nice with CTP. MELD score basically is used to prioritize a patient on the waiting list. It also gives you the risk of morbidity and mortality while a patient is on the waiting list. But essentially, we all forget that the fundamental discovery of the MELD score was in order to identify which patients would benefit from TIPS. And TIPS was being discussed, and one or two very, almost sexy points that I would like to talk about TIPS is that, TIPS is like an engagement. સગાઈ ક્યારે કરો? લગ્ન કરવાની તૈયારી હોય ને તો જ સગાઈ કરાય. લગ્ન કરવાની તૈયારી ન હોય ને સગાઈ કરો ને તો છોકરી પ્રેગ્નન્ટ થઈ પછી શું કરો? That is the problem. So when you do a TIPS, you have a risk of acute decompensation in about 40% of the patients, depending upon the MELD score. If your MELD score is more than, say, 20 and you do a TIPS, what happens is that, the liver is being perfused with a very high pressure in the portal vein. And about 50% of the diameter of the portal vein may be maximum, 12, 14, 16 millimeters. And then you put a TIPS of 6 to 8 millimeters, which means like 50% of the venous caliber as well as the pressure is going to be diverted straight into the right atrium. And that essentially means that you can precipitate an acute decompensation in the patient, necessitating an urgent transplant. You may also precipitate, like Dr. Harshal Patel pointed out, hepatic encephalopathy and also right heart failure, because your sudden increase in the venous return is overwhelming in a patient who has cirrhotic cardiomyopathy or cardiomyopathy secondary to chronic alcoholism as well. So TIPS is we in a fluidly decompensated patient, we make sure that they have a reserve of a living donor worked up and ready to go, and only then you do TIPS. Otherwise, you do a TIPS, the patient deteriorates, and you'll have to see him die. So that is one very important caveat. Secondly, the utility of TIPS is best only when you do it for bleeding esophageal varices or portal hypertension, which is not being conservatively managed or is not being successfully conservatively managed. It does not work as well when you do it for just fluid overload or diuretic resistant ascites or ascites, which is now not responding to your diuretics, your sodium is dropping, your urea creatinine are going up. So those type of patients you can try, but generally won't work. The other thing I want to say is this terlipressin, somatostatin, yes, we use clinically for bleeding. That doesn't stop with conservative measures before you go to TIPS. But terlipressin is used for all types of HRS, type 1 and type 2. And, what happens is that, if you go into HRS, whether it is type 1 or type 2, unless you are able to reverse the HRS within about 6 weeks or 8 weeks of its onset, if your creatinine is continuing to be about 2 after 6 weeks of its onset, then you are more likely to end up with a combined liver kidney transplant. So there, the use of terlipressin along with albumin becomes critical. And it also signifies you try for 2 weeks, 3 weeks, your creatinine is not reversing, then you need to ring the bell and say, come on, pull up your pants and get a transplant done, either living donor or whatever you do, else you'll end up with a liver kidney transplant. So these things I just wanted to highlight before we go on to the role of liver transplant. And the role of liver transplant, we have all come from an era where transplant was not easily available. It was very costly. The
Anand bhai,
outcomes
do you
were
want
not
to share
reliable.
the screen or something?
મારી પાસે જે સ્લાઇડ્સ હતી બધી પોર્ટલ હાઇપરટેન્શન ની હતી. મને ખબર નહીં કે liver transplant ની તો ઘણું બધું છે. But I don't know whether slide sharing will help. One, because your time is already up. 9 થી 11
ના
માં તો
સાહેબ,
11:30
ના
છે.
સાહેબ એવું કાંઈ નથી. લોકો પોતાની ટિફિન લઈને બેસે. સી સ્ટડી
અચ્છા અચ્છા
એટલે
ના બરાબર.
તો
એટલે મેં સ્લાઇડ આની માટે તૈયાર કરી નથી, પણ I can pull up something, but it will basically, I don't want to make this August audience wait, because the students, I mean, there is a lot of faculty here who doesn't need to listen to me at all, and there are a lot
no,
of
the
students
faculty
who
are for you.
Yeah, we will listen you up, sir.
नहीं, Anand bhai, at least see at present in the screen I can see 5 professors. Right.
Yeah, so like I said,
have a question.
I have aspired all my life to become a professor, and I have never been I mean, honorary professorship હોય પણ એની કોઈ value નથી. I have never been able to achieve professorship. Haji sir.
Anand, I have a question.
Haji sir.
That all these patients are drained out with money for many years, bleeding, hospital,
Haji.
sclerotherapy, this, that. So by the time they come to you for liver transplant, how many people have enough money to undergo liver transplant? And honestly, how many liver transplants are done for portal hypertension? Can you give some figure?
Sir,
yours
also,
and others.
yeah, also include the best for the interest of PG student. Also include the best candidate for liver transplant when to carry out.
Yeah. So it is starting from Rupesh Bhai. Basically, very true. People have been drained because of long duration of treatment by medical gastroenterology physicians alike. And sometimes they undergo funny therapies. Some people undergo stem cell therapy and all those things that never work. And by the time they come to us, generally at least 50% of them will mention a significant strain in their finances. But because today we have a lot of financial options. Sarkar gives about 4.5 lakh rupiah to all transplant patients as an aid. The packages have come down to 18 lakhs. So 18 કાઢો એટલે 13 થઈ ગયા. 13 લાખમાં transplant બહુ ઓછા માણસો ના પોસાય. Finances are very easily available. Because whatever profession you may be doing, you can get a personal loan of 10 lakh rupees at the fall of a hat. So people do come with financial strain, but I don't think that many people would not undergo liver transplant because of financial trouble. They don't undergo liver transplant for reasons like they don't have a living donor and they can wait on the cadaver donor waiting list forever. I mean, we have about 80% mortality on the cadaver donor waiting list. So those are the reasons. But if they have a living donor, and then we have other options. We have crowdfunding. We always have, like, anytime I have at least 5 patients who keep telling me, "Sir, કોકને મદદ હોય તો કહેજો ને કે આપણે 1, 2, 3, 4, 5 લાખ રૂપિયા સુધી આપણે આપવું છે." So money in today's world is not as big a problem, particularly because we have reliable outcomes. ઓલું હોય કે 25, 30, 40, 50 લાખ રૂપિયા નાખો અને તો એ 50% outcome છે, તો people will not have money. But if you say 18 lakh rupees and 90% outcomes, then it is not difficult, particularly when you have some aid coming from the government as well. So that is one. Two, almost all the transplants are done for portal hypertension, except those that come with HCCs that are not resectable. Even say when you talk about NCPF, we don't transplant NCPF unless they behave like cirrhotics. EHPVO, we almost never need to transplant. The livers are essentially normal, but very rarely, like right now, we have a patient who has EHPVO along with cirrhosis, and that becomes very challenging because you don't have a supramesenteric venous inflow. And this guy, you have options like giving them a jump graft from the left renal vein or doing a hemiportocaval transposition, but they have only 50% outcome. So we generally prefer to do a multivisceral transplant for these patients. So we would do a combined liver small bowel transplant. And the funny part is that when you do a combined liver small bowel en bloc, you get a free pancreas along with it. That's the beauty of it. But anyway, that's just for fun. So yes, almost everybody is for portal hypertension except those rare non-resectable or multifocal HCCs who may be compensated but not resectable. And then we would do a transplant. And the last question which Apurva Bhai asked was what I am sorry. Can you repeat that question?
Best timing for
Best
liver
candidate. Timing.
Yeah.
Yeah. So like I said, see, what the prevalent mindset is that you transplant a patient only when only when they have floated decompensation, they look like ICU patients, and they have diuretic resistant ascites, so they have repeated episodes of hepatorenal syndrome or hepatic encephalopathy. But anybody who is decompensated is going to need a transplant. And then you time the transplant based on their comorbidities as well as the degree of the clinical severity. So whenever you have a child stage B liver disease, you send these patients to a liver transplant center so that his disease can be appropriately staged, his comorbidities can be assessed, his availability of living donor as well as financial constraints can be identified. And that is when you can appropriately advise a particular patient for the timing of transplant, the type of transplant, and what are the resources that he might need in order to be able to successfully undergo transplant. But these luxuries are available only for child trachea tube stage B. When you are in CTP stage C, then you really don't have the luxury of time, as well as you are facing a significant severity of clinical disease. You are at a threat of going into multi-organ failure in terms of hepatorenal syndromes, multiple episodes of HRS, significant portal hypertension, splenomegaly, and patients develop complications, and they go from one complication to the other. They give you windows in between in which you might need to grab him and do a transplant, and that luxury doesn't always work. So the mortality and morbidity in CTPCs are higher than CTPBs. So I would consider it a moral obligation for all practitioners that whenever you have a decompensated liver disease patient, you know that the density of cirrhosis in those livers is more than 70%. These cirrhotics are not reversible. You can treat them conservatively with diuretics and albumin infusions and nutritional and physical rehabilitations only up until some time. So they need to be educated about where they are and their eventual fait accompli. So that is, but then we don't refuse anybody, irrespective of whether their MELD scores are 40 or 44 sometimes. They're high risk transplants. They have a longer duration of ICU stay. They have a higher incidence of requiring perioperative dialysis. Their their consumption of blood and blood products is higher. So eventually their costs and morbidities and mortalities, they go on the lesser side. But then that's the world we live in. So if you ask me what is an ideal patient is somebody who is CTP B9 with a MELD score of less than 25. And these patients would have the I'm talking to a lecture. So these CTP B9 with a MELD score of 25 and not having comorbidities that would jeopardize the outcome in terms of, some people have with NASH, they have some people with NASH, they have a significant coronary artery disease. They require
POS, please. Yeah, please.
Yeah. So, like I said, in terms of liver disease, B9 or above would definitely not succeed or not even fare well with conservative management. And before they go C and multi-organ failure, so their costs and outcomes can be better. Comorbidities, if they are bad, like NASH patients, elderly patients who have concomitant coronary artery disease, may need stenting, or some of them we do CABG and liver transplant at the same time. So those are bad patients. They have multiple complications. Renal compromise at the time of transplant has a 30% perioperative mortality within 1 month. So as much as possible, you correct the kidney before the transplant, and if the kidney is not correctable, then you accept as higher mortality or do a simultaneous liver kidney transplant. Having said that, one more important characteristic is cachexia. Patients who have suffered protein energy malnutrition because of a prolonged duration of conservative management, and physicians don't always adequately focus on nutritional rehabilitation. So a loss of muscle mass is associated with a lot of reduction in the cell-mediated immune responses in these patients, and then when they undergo this massive surgery, transfusions, boluses of steroids, and immunosuppression, then this cachexia, starts playing a role, and the perioperative periods are very turbulent, and they end up with a higher morbidity, mortality, and cost. I don't know. Does that answer your question?
Yeah, you have covered it, sir. You have covered it very well.
I will have to go, and thank you very much, everyone.
Thank you, sir. Thank you. Thank you for being
It's up to 11, and I have.
Okay.
Yeah.
Thank you,
Yes, sir.
Anand bhai, please continue with
Yes.
the overview on liver transplant.
Yes, sir. So, regarding the role of liver transplant, like I said, all decompensated cirrhotics are going to need a transplant. We time the transplant based on the degree of clinical disease as well as comorbidities, and there are the variety of options. If somebody there's a big myth that you go on the list and then you can wait safely. That never works, because the lists are ruled by the MELD score. And it does not matter whether you come on the list early or late. Only those with the highest MELD score are going to get the organ. And that essentially means that if you have stable disease and if you woke up early, then being on the list is not going to help you. It will help only if you have a living donor. So if you look at this patient population with the intention to treat analysis, patients who have a living donor have a much better outcome as compared to those who don't have a living donor and are dependent on a cadaveric donor for their transplant. There are people who have acute liver failure. Again, they don't have the luxury of time, and they have limited options for living donors as well, because in that moment of crisis, you can't really go fetching distant relatives, and then oftentimes they don't have blood group compatible donors. So we do ABO incompatible living donor liver transplants in an emergency as well. Now, this is very interesting because If you look at the standard literature for ABO incompatible transplants, it requires you to identify and measure the IgG and IgM anti-blood group antibodies. Like for somebody who is blood group A, you need to measure his anti-B antibody, and depending on the titer, you will have to reduce them down to less than 1:32 using plasma exchanges and rituximab, and that could take up to 2 to 3 weeks. And we don't have that time, we have less than 24 hours. So what we do is we put them on continuous plasma exchange using candles, and we keep on ferracing them using candles until their titers come down to 1:32. We don't give them rituximab. We take the liver out early, put them on the portocaval shunt, and on shunt we do a splenectomy before putting the graft liver in. And this basically eliminates the chances of him making, or that patient making more antibodies intraoperatively as well as postoperatively. So we've done about 10 in the last 2 years, ABO incompatible in an acute liver failure. And with God's grace, I can tell you that nobody has had a rejection, even without rituximab. That everybody is alive is another matter. I can't say all acute liver failures do survive. They survive is about 80 to 90%. These 10 that we have done have all survived, and only one needed 2 plasma exchanges post-operatively, but the rest didn't even need a single plasma exchange post-operatively. So the scope of liver transplant in acute and chronic liver disease has evolved a long way. Patients with a background of compromised kidneys in terms of chronic liver disease as well as type 1 and type 2 HRS, which don't resolve for up to 6 weeks and beyond and are on dialysis at the time of transplant, we do a simultaneous liver and kidney transplant. You can do sequential as well, like you do a liver transplant even if it is more than 6 weeks, and there is about 30% to 50% depending on the patient population chance of that reversing back. But the other 50 to 70% that don't revert the kidney functions, you have the option of doing another living donor kidney transplant within 2 weeks of the liver transplant, and then preventing the 30% mortality within the first month of liver transplant as well. So liver transplant as a field has come a very long way in terms of the variety of options, the costs. In acute and chronic liver failure is the other group that has become very popular these days. Up until like even 5 to 8 years ago, acute and chronic liver disease, particularly alcoholic, were not eligible for transplant. There used to be a dictum that unless you have at least 6 months of abstinence, you don't offer a liver transplant. Now, that has gone out of the window. But even somebody who comes with an acute and chronic alcoholic liver disease, you can do both living donor as well as a cadaveric liver transplant. Even they're eligible for cadaveric liver transplant. So the game has essentially shifted. We have an ICU full of ACLFs all the time. And the only set of patients who get cadaveric organs are acute and chronic liver failures because their MELD scores are always more than 30. And therefore, these acute and chronic liver failures, they are in a state of systemic inflammation. And because they have systemic inflammation, all patients are in DIC at the time of transplant, but these ACLFs have an escalated level of DIC. So all cadaveric organs go to ACLFs. All ACLFs have systemic inflammation, flooded DIC, and therefore the outcomes of cadaveric liver transplant have deteriorated as compared to what it used to be earlier, when most of the patients receiving a cadaveric liver grafts were, stable cirrhotics, and a lot of them were HCC patients, because HCC used to be given MELD exception points. Now, in Gujarat, we don't get any MELD exception points for HCC. That means almost no HCCs get a cadaveric liver. They will have to take a living donor, otherwise they have to die. And all patients who get a cadaveric liver are ACLFs. So the cadaveric liver transplant outcomes, which used to be around 90-95, have now come down to around 80-85 because of this change in the way patient selection is allowed in the system. One more pathophysiology which comes into our way, and again relevant to portal hypertension, is that one of the most dreaded manifestations of portal hypertension is portopulmonary hypertension. Portopulmonary hypertension either resulting into elevated pulmonary artery pressures, along with sometimes fluid overload, and sometimes a hepatopulmonary syndrome, not portopulmonary hypertension, hepatopulmonary syndrome where you have fluid in the lungs. So these patients, when you try to tap their ascites is okay, but when you try to tap their pleural effusions, the incidence of bleeding is higher because you don't have that tamponading luxury in the thorax. their morbidity following TAPS is very high. They bleed and they die. And more than that, in portopulmonary hypertension, they have large shunts in the thoracic space, intrapulmonary shunts as well, elevating their PA pressure. So you will have to put them on sildenafil, dry them out, bring the systolic pulmonary artery pressure, that is end diastolic right ventricular pressure, to below 50, somewhere around 40 preferably, and make them an acceptable candidate. And then what happens is that when you reverse the portal hypertension, as in when you reperfuse the graft, there is a massive collapse of all the small size shunts, and there is a massive influx on the right side of the heart. The venous return jumps rapidly, and these patients, they tend to go into a right heart failure immediately after reperfusion, during the reperfusion syndrome phase. So these are the things that you need to watch out. You need to know your patients. Being a surgeon does not allow you to not be a physician if you are doing liver transplant. And you need to know hepatology as much as the hepatologist. You need to know critical care as much as the critical care guy. It is not his job. You have to manage the ventilator. You have to put them on cardiac index monitors. You have to measure the systemic vascular resistance. You have to see the stroke volumes, mixed venous saturations, and you have to appropriately treat them in the perioperative period using inotropes in that fashion. You need to know where you need to reduce the pressure. Is it in the form of afterload, or is it in the form of increasing the cardiac output, or is it that you need to selectively dilate the pulmonary artery circulation? So this is something very exciting and very interesting and very unique to liver transplant, that you need to know as much medicine and as much critical care as those specialists. What I find most exciting and what I find most interesting, and it is so addictive that once you start doing these liver transplants, then you don't like to do anything else. That's all you want to do. So I can keep on speaking, but I would rather let somebody ask specifically.
Any questions by the PGs, or I think Kirit has gone? Okay.
No, I am here only.
हाँ तो किरीट भाई के बीजा प्रश्न.
No, sir, I just wanted to ask that only, that sir has nicely explained, as there are so many PGs and even for us also, liver transplant, who is better than sir can tell us. So at least PG should know what are the indications, in which patient you should be done, what are the different types, and what are the results. So sir has very nicely summarized. So I don't think, at least I don't have any questions right now.
Sir, I would like to ask, sir, just emphasize on this overall success rate. What is disease donor liver transplant success rate compared to living donor liver transplant? What is that graft survival? So overall view of that.
Yeah. So there are 2-3 elements in this. If you compare head to head, like 10 cadaveric liver transplants versus 10 living donor liver transplants, the outcomes are the same. There is no difference in that. But if you do an intention to treat analysis, like you have a group of 10 patients where they have a living donor versus a group of 10 patients where they don't have a living donor, then in the group that does not have a living donor within 1 year, if they are CTPCs, then there will be at least 30 to 50% mortality. So out of those 10, 3 to 5 patients will die in the waiting list. And out of the 5 or 6 that undergo a transplant, you will have the same 90% outcome. So at the end of 1 year, in the group of 10 patients that did not have a living donor, about 5 patients at best would be alive, versus those that had a living donor. Out of those 10, 9 will be alive. So even though the head-to-head comparison, the outcomes are very, very similar, but in an intention to treat analysis, living donor liver transplants are far superior as compared to the other group. That is one. 2, there was a time when we used to believe that the MELD score indirectly tells you the burden of the physiology, how sick is the patient. And if the patient is very sick, or if the MELD score is very high, then you need a lot of liver to meet the metabolic demands of the failed graft, the decompensated patient, and the burden of the perioperative events. But that is not true anymore, particularly if you have a graft to recipient weight ratio of 0.8 or above, or a minimum graft size of at least 650 grams or above. What am I trying to tell you for the PGs? I'll elaborate is that if you have a 70 kilograms recipient, then the graft to recipient ratio of 1 means 700 grams. So that is ideal. Okay, it will function just as much as a normal liver. The normal liver is about 2% to 2.25% of the body weight. But if you are to transplant, if you transplant 1% of the body weight, it will be sufficient. Now going down, what is the bare minimum to get sufficient prompt liver function? It is 0.8. So that means that out of 70, you can take out 140 grams, so at least 550 grams for a 70 kilograms man should be okay. If you go to a graft to recipient weight ratio of 0.7 to 0.8, then you have a mild risk of small for size graft syndrome, which means that the prompt liver function, the immediate liver function, might fall a little short of what is required to meet the physiologic demands of the patient undergoing transplant. And this means that a longer duration of ascites, slightly longer time for the INR and the coagulopathy to correct, they are all in florid DIC, and the graft function, as it picks up, will mop up the DIC and bring or restitute the patient's homeostasis. So that gets delayed. So there is a higher rate of transfusion. There is a higher rate of, conservatively managing the ascites, coagulopathy, and those functions. So they have associated morbidity and mortality along with mild risk of small for size graft syndrome. If you go further below, from 0.7 to 0.6 of graft to recipient weight ratio, you have moderate risk of small for size graft syndrome, and there is a significant mortality in these patients. And if you go below 0.6, then I say you might as well kill the patient without a transplant. Okay, so that has a very high mortality. And the reason why they have mortality is because the cell-mediated immune functions which the liver brings is not substituted by anything else that you can transfuse. You can give everything from outside. You can give blood products. You can even give synthetic products. You have fibrinogen powder instead of cryoprecipitates. You can give PCC, concentrated prothrombin complex concentrate, so that your transfusion is low. But those things will not give you the cell-mediated immune responses, and these patients die from sepsis. So that is one thing to know about how much graft you need to give. And then the things about, can you split a liver? Yes, you can split a liver, but the liver in a cadaveric split liver, you have to remember that the cadaveric organ was inside the body of the man who died. Okay, brain death is associated with what is called the cytokine storm and a gradually depleting endocrine support from the hypothalamus to pituitary to the major endocrine organs. So when you have brainstem death, the pituitary supply of, say, ACTH to the adrenal cortex ceases. The TSH to the thyroid ceases. So what happens is that, most people don't realize that the noradrenaline and the adrenaline receptors in the vascular endothelium are chemical receptors for which you need the trophic support of thyroxine. So if your thyroxine is dying, as per the half-life of the fading thyroxine, you will also have a fading of noradrenergic and adrenergic receptors. And gradually you will enter a phase of vasoplagia. And this vasoplagia will ensure that no amount of inotropes that you give will restitute the perfusion pressure to the liver. So a variable amount of hypoxic hypoperfusion injury is suffered by all these organs. So you cannot treat a cadaveric split with the same graft to recipient weight ratio as you treat a living donor graft. In other words, if you are trying to split a liver and if you are measuring the weight of the split liver that you get to the weight of the recipient, the minimum graft to recipient weight ratio there, what you would consider 0.8 in a living donor, would be 1.25 in a cadaveric liver. And that too, you have to still understand ultimately at the time of retrieval, what were the liver enzymes, what was the duration of ischemia, was there hypoxia as well? Why hypoxia? Because just as the adrenal cortex is just as the thyroxine is dying and the noradrenergic adrenergic receptors are dying, so also the adrenal cortex is dying. And when you have when you don't have ACTH and your glucocorticoids are tapering off as per their half-life, you have a loss of semi-permeability in membranes. So these patients, irrespective of how you increase their ventilatory settings, they will start flooding their lungs. It will make it difficult for you to ventilate them. There will be a variable amount of hypoxia, and these injuries will also matter. And this will have a bearing on your graft. So these pathophysiology of brain death and how it impacts the liver parenchyma is something that has to be borne in mind when you go into complex endeavors like splitting cadaveric livers and so on.
Sir, how do you select a live donor, and how do you resect the liver for? How do you harvest the liver for live donor?
Correct. So there are 4 basic selection criteria for living donors. One is that they have to be related, not because there is an immunologic advantage, but because it's a legal requirement. Can be near or distant relatives, but they need to be related. Secondly, the donors that we allow normally are more than 18 years, because otherwise they can't give consent, and less than 55 years, because after 55 years, the liver regeneration is questioned. In very fit, very healthy donors, we even go up to the age of 60, but never beyond 60. At the same time, we do not, as far as we can, we do not take donors who are known to be diabetic, because NASH is the biggest deterrent to liver regeneration. At the same time, we also try to avoid patients who have history of alcoholism from becoming donors, because even if the livers are fine, even if they're not fibrotic, they are not so fatty, but you cannot rely on them becoming alcoholics and coming back with cirrhotic livers and liver transplant getting a bad name. So no alcoholism, no diabetics between 18 and 55 years of age, and related donors. These are the entry criteria. But once you enter, the selection begins in like 5 steps. The first step, which we call phase 1. Phase 1 includes complete blood count, renal function test, liver function test, HbA1c, lipid profile, HIV, HbSAg, and MTHCV. If these are acceptable, then the next step will be, and again, when you say acceptable, we would even accept up to twice normal transaminases. Like, if you have a SGOT and SGPT less than 75, we really wouldn't mind, except we would look into what is causing it. But they will not be barred just because their enzymes are high. But then after this blood tests, we do a plain CT scan where the liver attenuation index is the comparison of the Hounsfield units of liver minus spleen. And if it is more than +6 liver attenuation index, then the chances of the liver having more than 20% macrosteatosis is less than 10%. So that is the preferred cutoff. But having said that, if somebody is between the range of +2 to +4, we would then do a liver MR elastography and biopsy as well if needed, to make sure that some of them may have an acceptable fat. And people who have hemochromatosis, a high iron load, sometimes can give you a false high LI as well. So we have to look at the plain scan and see in the plain CT scan as to whether you can see the hepatic venous and portal venous blood pressure against the liver parenchyma. If you can see them clearly, then the fat and the inflammatory index is going to be acceptably low. If it is less than 0, then we would generally not accept these donors for risk of higher macrosteatosis. Once the plain CT scan is acceptable, then we do a contrast-enhanced CT scan. And a contrast-enhanced CT scan will allow you to do 2 things. It will give you the volumetry. This is a very tricky thing, very, very tricky thing. Why? Because what we are going to cut inside is based on an ischemic line between the right and the left anatomic left lobes. Obviously, it is not the falciform ligament. It is the Cantilese line, the line joining the IVC to the base of the gallbladder fossa. That is the anatomic right and left. But again, we identify it on the CT scan based on the lie of the middle hepatic vein. And based on the lie of the middle hepatic vein, we estimate the volume of the left lobe versus the right lobe. And for the right lobe, when you measure the volume, you have to give a 0.85% correction, which means the density of the liver is less than 1. It is only 0.85. So if you have a 700 cc of liver, then you will get 600 grams of liver, because what you need is the recipient to graft weight ratio, not volume ratio. So we have to measure the volume of the right lobe and convert it into weight for you to see whether that is going to be an acceptable weight of the graft for the recipient. But at the same time, what you're leaving behind in the donor has to be measured in terms of volume. So for a donor of, say, less than 45 years of age, we would accept up to 30% at least residual volume. So if the liver is 1 kilo in weight, then we would require the residual volume of the left lobe to be at least 300 grams or more for it to become an active. If it is 250 grams, we would simply, even 28%, we would reject. Why? Because you can get away with up to 25, but then there is a 5% error in the radiological estimation. So you to always keep that margin. So, if you say 30%, it can be 28, 27, and you get away. But if you take 27, if it is 5% low, 20%, then you are dead. So we would accept up to 30% and never below. But if you have a donor of more than 50 years, we would accept not less than 35% residual volume in the donor liver. So this is the volumetry step. Second is the intrahepatic anatomy of all four structures. In the CT, obviously, we will know only the hepatic artery, the portal vein, and the hepatic veins. And the hepatic veins can be whatever they want to be, and we will reconstruct them on the back table. But the portal vein and the hepatic artery have to be very accurately assessed. We can take up to 1 or 2 hepatic arteries, but if you have a graft which has 3 hepatic arteries supplying that lobe, then we would shy away because of a risk of higher percentage of hepatic artery thrombosis. But then these vessels are, a single hepatic artery would be somewhere around 2 to 3 millimeters in size, but if you have 2, it will be like 1.5 to 2. If you have 3, it will go to like 1 to 1.25, and that becomes dangerous. It is smaller than the coronary arteries after that. So it's easiest if you have an accessory right coming from the supramesenteric artery, then you get a long stem. They will tell you, where is the cystic artery coming from? Is the cystic artery coming before the right anterior and posterior sectoral arteries are dividing? Then great. If not, it's fine, but not more than 2 arteries. That is the dictum. Portal veins are more difficult to reconstruct. So if you have 2 portal veins, we would really look carefully as to the distance between the 2 portal veins and whether we will have a graft retrieved from the recipient's liver, which will allow us to create a Y single inflow. Never ever try to do 2 portal vein anastomosis in the recipient. Why? Because the graft, when it reperfuses, it alters its shape. And when it alters its shape, what was patent will become occluded or angled, and portal vein thrombosis is tolerated poorer than hepatic artery thrombosis. Hepatic artery thrombosis, you can go in and redo, patient survives with some abscesses. But portal venous thrombosis, the mortality rate is very high, even though the incidence of portal venous thrombosis is lower. So single portal vein, no problem. 2 portal veins, make sure you know what you're doing. 3 portal veins, and I have done it only 2 or 3 times, like we did one last time, and we may be doing again. But 3 portal veins are very, very dangerous, and we would not do it unless the patient really needs the liver urgently, and it's an act of desperation. But never ever something that compromises the donor's portal vein. So if there's any question about whether it will narrow the donor portal vein in an effort to take out 2 or 3 portal branches to the right lobe, we would absolutely abandon that. Bile ducts, one is ideal, type 1, type 2, type 3, type 4 anatomy. And there is nothing that we would not take. I mean, yes, it would be great to have 1. It is okay to have 2. It is bad to have 3. It is really bad to have 4. But then, what it has is what it has. So the recipient hepatectomy technique depends upon the anatomy that you have in the donor. And there's a huge difference between the recipient surgery if your graft is cadaveric versus the recipient surgery if your graft is from a living donor. For a recipient surgery in a living donor graft, we would go very high up in the hilum, and we would take the bile ducts up inside the liver, along with the liver, so that you will have at least 2 or 3 branches, at least 2. If you're less than 2, then it's bad surgeon. So preferably at least 2, preferably 3 bile ducts on the donor side, and we will always preserve a long stump cystic duct in order to manage something that was not seen on the MRCP but is seen in intraoperative cholangiogram in the donor. So this is so far as the donor selection goes. The surgery, there are principally many techniques of doing surgery, and traditionally we use one of these 2. Either we have a Cavitron ultrasonic surgical aspirator. We have 2 companies. One is from Integra, which is the best machine, but it costs something like 75 lakhs. So a lot of times some programs have a Sonoka Sorel's which is about 30-35 lakhs, which is just as good. We are lucky we have the Integras, and we also have Irby's water jet dissector. So we use these two tools variably depending upon the stiffness of the liver. If the liver is stiff, then CUSA is mandatory. But if the liver is not very stiff, then water jet does wonders. Water jet will delineate much clearer. It's a little slower, but it will delineate the intrahepatic vessels much better. It will give you all the clarity to clip, tie, laser seal, do all those funny things. If you want to do it fast, then you can start with cheliclysis up until you hit the first junction. The first junction is between either 4B and 5 meeting to initiate the formation of the middle hepatic vein. And at that point in time, until that point in time, you have no worries. You can simply go with a cheliclysis, and that will save you like half an hour of resection time. And then on, you have to decide whether you are going to be on the right side or the left side of the middle hepatic vein, depending upon whether you have a fissural vein supplying segment 4 of the left lobe up until the IVC, or you are going to rely on the middle hepatic vein to drain segment 4 into the cava. So if you're relying on the middle hepatic vein, you'll always stay on the right side. And then you have the burden of reconstructing the segment 5 and segment 8 outflows, which normally flow in through the middle hepatic vein, but now they are isolated, and you will connect them via either a cadaveric venous graft, or we use heparin bonded PTFE grafts to connect them and then make a single venous outflow along with the right vein into the IVC. So that's for the back table. But yes, we use generally these cheliclysis to start sometimes, but generally CUSA and or water jet dissector depending upon the parenchyma. There are people who use harmonic, but we would not, because it will char the tissues, it will burn bile ducts, which you will not see on the back table, and then you have bile leaks from the cut surface. So no harmonics, no vessel sealers, but CUSA, water jet, and good old standard surgery. And we use a bipolar cautery, sometimes a irrigating bipolar, but irrigation is essentially given up unless if somebody has very bloody resection, then yes, we would use an irrigating bipolar, but generally it's not an irrigating bipolar, just regular bipolar along with these instruments. Takes about 2 to 2.5 hours for the resection, but you are never allowed to do a Pringles, even partial, even for a short time. So that part has to be done with a lot of caution, peace of mind, music, and pleasantness. If the surgeon is irritated or irritable, or you have an anesthetist who is nagging, or the mood is not good, then change the guy. Is that what you asked, or did I answer something else?
Yeah, no, absolutely, bang on. Any more questions? I think then we can leave on that note, with the hope that we may complete we may have the whole lecture on liver transplant by Dr. Anand Khakkar in near future.
It's a pleasure. I would look forward to an opportunity to spend an evening with you guys, and I promise we'll host the dinner.
Okay, on that note, Anand bhai, anything left out?
No, sir.
Anand Patel. Okay, Arshal bhai.
Yes, sir. Very, very informative.
Okay, Darshan.
Thank you, sir. It's a very informative, sir.
Kirit bhai, thanks for helping out at the last moment.
Yeah, thanks, sir. Thanks.
Okay,
It was
we'll
my
leave
pleasure.
on that note. Thank you all.
Okay, thank you all.
Thank you, sir. Thank you.
Thank you, sir. Have a good day.
Good day.